Okay. Assalamu alaikum, everyone. Let me just share my screen. Okay. So, assalamu alaikum, everyone. My name is Marwa Kaidali, and I'm a fourth year medical student. And today I'm going to be teaching you three lectures. I'm going to be teaching you tubular functions 1 and 2, and then we'll be covering urine dilation and concentration. Okay. Now, if you feel like I'm going too fast or if you're not understanding something specific, please feel free to let me know and tell me to repeat. I don't mind. And this lecture might seem a bit heavy because it does have like a bit too many things, a lot of channels and stuff like that. But again, I'm going to try and repeat the important stuff, what inshallah is going to stick. So let's begin. 1 second. Okay. Okay, so first we're going to start with tubular functions 1 and 2. Okay. So these are the contents that we're going to be covering today. So first we're going to be covering a few basics of reabsorption, and then we're going to uh, okay, and then we're going to go over each segment of the nephron and talk about which channels are present in each segment, and then we're going to cover some hormonal regulations that are going to regulate some ions. We'll see that later, and then we're going to end it off with a clinical disease that the doctor mentioned in your lecture. Okay, so let's first. Wait, can you see my camera? No. Okay, thank you. Okay, so first let us start with the basics of reabsorption. So first, there are two main pathways for reabsorption. Okay, so the first pathway is the transcellular pathway, and the second pathway is the paracellular pathway. Okay, now when we say paracellular pathway, we're talking about ions going between two cells. Okay, but when we talk about the transcellular pathway, it is when an ion is going across a cell. I have a picture for you guys, just 1 second. So for the transcellular pathway, it is further divided into passive transport and active transport. Okay, now if you see over this picture, over here we have the paracellular pathway, which is when an ion is going between two cells, and then the transcellular pathway when it's going across a cell. Okay, and all of these channels or path or examples are examples of transcellular pathway. Okay, so again, transcellular we have passive and active. Now passive is further divided into diffusion and facilitated diffusion. Now diffusion, as you already know, is when an ion is just going to diffuse across a membrane. And facilitated diffusion is when an ion is going to use a carrier protein to diffuse across a membrane. So it's facilitated basically. It gets help from a carrier protein. Okay, so this is for passive transport, for the transcellular pathway. Next, we have active transport. So again, we have two types of active transport. We have primary active transport, and we also have the secondary active transport. So primary active transport is when we have a channel that is using ATP. Okay, so in our case over here, we have an example called the sodium potassium ATPase. Now this channel is going to be using ATP. Okay, and then we have secondary active transport, which is basically going to take the gradient that was formed from the primary active transport to use into this channel. So, okay, let's take an example. Again, over here we have the sodium potassium ATPase, which is our primary transport. And then we have here a sodium glucose transport. For this channel to work, we're going to take the gradient that was formed from this primary active transport into here. So basically this works thanks to the to this channel, which was a primary active transport. Okay? Next, we're going to look at a few driving forces for transcellular reabsorption. So the first one, as you already know, it's when an ion moves from an area of high concentration to an area of low concentration. Okay? That's very simple. The second one is an electrical force. It's when, if you look over here, we have an area that is highly positively charged. So we have a lot of positive charge over here. And this area has not that much positive charge. So it's mostly negative. So what's going to happen is that it's going to push these positive ions, some of these positive ions to the other side in order to equalize both sides. Okay? So that's the electrical force. And then over here, we have the concentration difference. So both of these, they act as the driving force for the transcellular reabsorption. Are we good so far? So this is just a picture to show you the driving forces. So again, over here, if you look, we have a high concentration of sodium compared to intracellular low concentration. So this is going to push the sodium to go into the cell. And over here, we have a low charge. We have -3 millivolts compared to the inside of the cell, which has -70. So if you imagine that there's sodium over here as well, it's going to push, sorry, 1 second. really sorry about that. Okay. Let's go back. 1 second. Oops. Okay. Again, really sorry. Okay, so back to what I was explaining. So we have different driving forces for transcellular reabsorption. So over here, we said that there is a higher concentration, which is going to push sodium inside of the cell. And now over here, we have a low positive voltage. And this is going to push these positive ions to go inside of the cell in order to make the inside of the cell less negative. Okay, because the inside of the cell is too negative. Okay, we're going to see examples later on of how these driving forces work, but this is just like a general idea or a general overview. Okay, so is it clear for everyone so far? Because we're going to go into our next part, which are the nephron transports. So is everything clear? Okay, thank you. So first, now we're going to start with the actual bulk of the lecture, which are the nephron transports, and we're going to cover each segment separately. طيب? But the first one we're going to start with is the proximal tubule. Okay, and the proximal tubule is actually divided into two. So we're going to have the first half of the proximal tubule, and then we're going to have the second half of the proximal tubule. Okay, and both of these, they have like different channels. This is why they're divided. So let's start with the first half of the proximal tubule. So just to orient you guys, we're going to have the tubular fluid over here, and then this is the tubular cell. This is going to be the interstitium, and this is going to be the blood. Okay. Now, when I talk about the apical membrane, which I'm talking about this one over here, this means that the apical membrane, think of it as the top. So it's going to face the tubular fluid. Okay. Now, when I talk about the basolateral membrane, this means that it's at the bottom, so it's going to face the interstitium and the blood. So our main goal over here is to basically like bring the ions into the cell through the apical membrane and then out through the basolateral membrane. Okay. Now, the first channel that we're going to see in the first half of the proximal tubule, is the sodium organic solute symporter. Okay, so this is basically the X stands for all of these. We have glucose, amino acids, phosphate, and lactate. So all of these, they're going to be combined with sodium and have their own respective channel to go into the cell. So I didn't put separate channels for each because it would overcrowd the slide and didn't want to confuse you guys. So basically X stands for all the organic solutes. So we're going to, each of the organic solute, they're going to each get their own channel with sodium. طيب? And then these organic solutes, they are going to leave the cell through this organic solute, through facilitated diffusion with the help of this carrier. طيب? And then over here in the basolateral membrane, we're also going to have a sodium-potassium ATPase, okay? And this ATPase, what is it going to do? So we said that this is an example of a primary active transport because it uses ATP. So what is it going to do? It's going to establish an electrochemical gradient. Basically, it's going to make sure that the concentration of sodium inside of the cell is low, so that sodium can keep on coming in, and so that this channel can keep on working. Okay, so it's going to basically keep on this channel working. This is the function of this ATPase. And then the next channel we're going to see in the first half of the proximal tubule is an H+ sodium antiporter. Okay. Now, I'm not going to go. Okay, so basically, this channel is responsible for indirectly reabsorbing bicarbonates. Okay, I have another slide that literally the next one talks about bicarbonate reabsorption. So I'm not going to explain right now the details of how bicarbonate reabsorption occurs, but just keep that in mind for now. So we have an H+ sodium antiporter, which is going to cause the indirect reabsorption of bicarbonates. طيب? The other thing we're going to see in the first half of the proximal tubule, okay, before that. So now that we have reabsorption of solutes, what do you think is the osmolarity of the tubular fluid compared to the interstitium? Because now we're taking in solutes. So what do you think is the osmolarity now? Low, exactly. So we're losing solutes, so more water is left into the cell. So this is going to push water. This is going to push water to get reabsorbed by osmosis. Okay, so we have low osmolarity, so now water is going to get reabsorbed. And water reabsorption is very important in the proximal tubule. Okay, so we have a lot of water reabsorption that's going to happen here. So again, in the first half of the proximal tubule, we have sodium organic solute symporter, we have the H+ sodium antiporter, which we will see in a minute, and then we also have water reabsorption. Next. So let's look into the bicarbonate reabsorption that I talked about earlier. So we said that we had this H+ sodium antiporter. Now, what is this going to do? Basically, it's going to bring the H+ outside of the cell. It's going to bring it into the tubular fluid. Now, this bicarbonate is coming from the glomeruli. And basically, our body needs bicarbonates. It's very important for us, and it's very important for acid-base balance, which thankfully is not my lecture. But basically, yeah, so we need bicarbonate into our body. But the problem here is that bicarbonate, it cannot get reabsorbed easily. Like because of its negative charge, it cannot go inside the cell. So we need a whole like breakdown process. So what's going to happen basically is that we're going to take this H plus. This H plus is going to combine with the bicarbonate, and it's going to form carbonic acid, also known as H2CO3. Okay, so when we have H2CO3, now this carbonic acid is going to get dissociated into carbon dioxide and water by the help of this enzyme called carbonic anhydrase. Okay, don't let the names confuse you. So this is carbonic acid and this is carbonic anhydrase. This enzyme is important because it's going to dissociate carbonic acid into carbon dioxide and water. Now, when carbon dioxide and water when they're formed, this is basically what you want, okay? So they're going to easily go into the cell, they're going to diffuse inside, and then with the help of carbonic anhydrase again, we're going to form carbonic acid, and this carbonic acid is then going to dissociate into H plus and bicarbonate. So this H plus is going to go back outside, so it's going to keep this channel going, so it's going to, keep on recycling and keep on going, and this bicarbonate is as we wanted, so we want to reabsorb it, so it's going to get reabsorbed, okay? So this is just a summary of all the transporters that I talked about. So on the apical membrane, we have a sodium organic solute symporter. And so we have a separate transporter for each organic solute. So we have one for glucose, one for amino acid, phosphate, and lactate. And something that I did not mention earlier is that the transporter for sodium glucose has a specific name. It is called SGLT2. So just remember the name. And then we also have a sodium H plus antiporter, and on the this is on the apical membrane, okay, which will help in the indirect reabsorption of bicarbonate. Then on the basolateral membrane, we're going to have a sodium potassium ATPase pump, which will help establish the electrochemical gradient that we saw earlier. And then we're also going to have the organic solute carriers, which are going to take the solute out of the cell. And then we're also going to have a bicarb carrier, which is going to help reabsorb bicarbonates. And throughout all of the membranes, we're going to have water channels, okay? Water channels for water reabsorption, which is very important here. So now, okay, this is everything that I explained in words because I know that I talked a lot. So this is everything in words. You can go over it. Now we're going to move on to the second half of the proximal tubule. So we said that we had a lot of solute reabsorption. We had sodium, we had organic solutes, and we even had water. So what do you think is going to happen to the chloride concentration? Because we have not talked about chloride at all so far. So what do you think is going to happen to it? Yeah, exactly. So it's going to be very, very high over here. Sorry, 1 second. Okay, so the chloride concentration is actually going to be very, very high. This is why this is going to act as the driving force for chloride reabsorption. So when you think of the second half of the proximal tubule, just think of sodium chloride reabsorption. We're going to want to reabsorb as much chloride as possible, okay? And sodium and chloride together. So how does this happen? We're going to have two pathways through the way this happens. So the first one is the transcellular pathway, and the second one is the paracellular pathway. Okay, now starting with the transcellular pathway, the channels we're going to see are sodium H plus antiporter and the chloride anions antiporter. Now I know we mentioned this transporter earlier for bicarbonate reabsorption, but right now we're going to be talking about chloride. So do not mix them up. Okay, so here in second half of proximal tubule, we're talking about chloride. Okay, so now these two channels, they're going to work together to help reabsorb sodium chloride. So what's going to happen is that this H plus and this anion, they're going to combine together, and then they're going to come back inside of the cell and then dissociate. So what's the purpose of this happening is so that the H plus can go back to its channel and keep on this channel recycling or just keep on working. And same thing for the anions. They're going to keep on going outside so that this channel keeps on working and we're taking more chloride. So essentially, we're basically taking sodium chloride inside of the cell. Okay? Now the sodium is going to leave the cell through a sodium potassium ATPase, and the chloride is going to leave through a chloride potassium channel. Okay, if you notice, I'm really trying to emphasize on the important points. Like for example, this channel, not that high yield, honestly. Okay, so that's it for the transcellular pathway of sodium chloride reabsorption. Okay, then for the paracellular pathway, we're simply going to have sodium chloride reabsorption paracellularly. Now, why does this happen? Because as we said, we have a very high concentration of chloride. So this is going to act as the driving force to push chloride paracellularly, okay? Because we have a high concentration, so we want to move it to an area of lower concentration, and it's going to take sodium with it. So we're going to have sodium chloride reabsorption paracellularly, okay? Now we're also going to have our water channels that we mentioned earlier. So we're going to have the water reabsorption throughout the proximal tubule, okay? So we have a lot of water reabsorption. Oops. Okay. So is this clear for you guys? The first half and the second half of the proximal tubule? Okay, perfect. Now we're going to talk about water reabsorption in the proximal tubule, which we have already briefly touched upon. So we already mentioned that water gets reabsorbed transcellularly, okay? But another way for water to be reabsorbed is paracellularly. So it can go in between the cells. And when it does that, there's a phenomenon that happens that is called solvent drag. What this means basically is when it drags, so when water gets reabsorbed paracellularly, it's going to drag some ions with it, okay? And of those ions are magnesium, calcium, and potassium. Remember, magnesium and calcium, they're going to be important because we are going to mention them later on. So again, when water gets reabsorbed paracellularly, it's going to drag some ions with it, and those ions are magnesium and calcium, okay? And now the water reabsorption that occurs in the proximal tubule makes up about 65% of the water that comes from the glomeruli. So from the total water, basically, okay? So there's a lot of water reabsorption that will occur in the proximal tubule, okay? That's it for the water reabsorption. Next, I'm going to briefly touch upon the protein reabsorption in the proximal tubule. So basically, proteins, they're going to come in the glomeruli, they're going to get filtrated, and then they're going to get reabsorbed in the proximal tubule. Now, what happens is that sometimes, in some cases, we're going to have a lot of protein, okay? And the way proteins get reabsorbed in the proximal tubule, that pathway is going to get saturated. So it cannot absorb any more proteins. So we're going to have a lot of proteins left over in the tubular fluid, and it's going to manifest as something called proteinuria, which is basically when you have protein in your urine, okay? So again, when you have a lot of protein, it can cause proteinuria because the reabsorption mechanism can oversaturate. Okay, so this is again everything that I said in words for the second half of the proximal tubule, and then we also have the water reabsorption. So this is my first checkpoint. So if you guys have any questions, let me know. Otherwise, we'll move on to the next part. Okay, I guess I'll move on to the next part. Again, if you guys are confused about anything, what is the charge of tubular fluid in the second half? Okay. So we mentioned here how we have a bunch. Thing is, the charge you're asking about the voltage, is not really mentioned. Like, it's not that important to know. All you need to know is that you're going to have sodium chloride reabsorption, and you're going to have a lot of like high concentration of chloride. So this is going to push it. But the actual charge of the tubular fluid, you don't need to know that. It was not mentioned. Thank you. No worries. Okay. Now let's move on into this part. So before I get into it, I just want to let you guys know that you do not need to know any of these drug names or endogenous anions or endogenous cations. Okay, you do not need to know any of these names. All you need to know or understand is the concept behind it. Okay. So to understand the concept, let's say, no, actually, so in our bodies, we know that we have a lot of processes that happen, and these processes can produce some toxic metabolites, okay? And also when we take drugs, you know how they get metabolized in our bodies, and they can produce toxic metabolites as well. And those toxic metabolites, obviously, they cannot stay inside our bodies. They need to get out because our bodies are not made to, store those toxic metabolites. So the way our body does that is through two systems. The first one is the GI system, and second one is the renal system, okay, which is our main focus, obviously. So the renal system is going to excrete these metabolites. And we're going to see how it does that exactly. So the first one is through filtration, and second one is through secretion. So let's start with filtration, and it actually makes up a small portion of the secretion of these toxic metabolites. And this is because these metabolites, they can be very big, and we know that the filtration barrier can only allow certain amount of molecules to pass through, and also certain sizes, because it's a very tight barrier. So a lot of these metabolites, they cannot pass through because they're too big, okay? So this is why the filtration makes up only a small portion of this process. So what's going to happen is that these toxic metabolites are going to be filtrated in the glomerular membrane, then they're going to enter the tubular fluid, and then خلاص, they're going to be excreted in the urine. So that's it for filtration. Now for secretion, it's when the toxic metabolites, they're present in the blood, okay? So they're going to be secreted into the interstitium and then enter the cells through these specific channels, and then they're going to get secreted into the tubular fluid, okay? So basically, we're going to have excretion of these metabolites into our fluid. Now, the problem with these channels is that they have a maximum transport rate. And what this means basically is that over time, they can get saturated. Okay, so they cannot excrete all of the metabolites that we have in our body. So this is why sometimes when you hear stories of people who, for example, they take too many drugs, like they cannot metabolize them, or they cannot excrete those metabolites. So they tend to accumulate, and it can be very fatal. Okay, so these channels, they have a maximum transport rate. So again, you do not need to know these names. And the toxic metabolites, they're also called as organic cations and organic anions. So that's it for this part. Next, okay, moving on to this graph. Now, this graph is so important. I cannot emphasize that enough, because if you would get a question from this entire lecture, I would assure you it's going to be from this graph exactly, okay? So Bismillah, let's get into it. Whenever we see a graph, we always need to first orient ourselves, okay? So what is this graph trying to tell us? It's basically telling it the x-axis over here is the tubular length, the proximal tubular length, and the y-axis is basically the ratio of the tubular fluid over the plasma. So we're trying to see the concentration of the tubular fluid over the plasma. Now let's start with with bicarbonate, glucose, and amino acids. When we talked about them, we said that they got reabsorbed, correct? So what would you expect their concentration to be in the tubular fluid compared to the plasma? For bicarbonate, glucose, and amino acids. This one. Exactly. So in the tubular fluid, their concentration would be low, okay? But in the plasma, it would be high. So now let me just try to draw this out. So let's say their concentration totally is 20, okay? Now let's say this is my tubular fluid, and we said that their concentration in the tubular fluid is going to be low because they got reabsorbed, correct? So let's say their concentration left is 5. And let's say this is my interstitium, okay? So we're going to have about 15 over here for the concentration of these solutes in the interstitium, okay? Now we're trying to see the ratio between the tubular fluid and the plasma. So from very simple math, we're going to divide these, and we know that when we have a lower numerator over a denominator, it's going to give us a value that is less than 1, okay? So this is why when you see the ratio of all of these solutes, you're going to see that it is less than 1, okay? I hope this makes sense. Now the opposites, let's talk about okay, 1 second. Okay. Now let's talk about creatinine. Creatinine, we have not mentioned it at all so far, but basically it does not get reabsorbed. However, it does get secreted slightly, but it is a bit it's a bit insignificant. So basically, how would you expect its concentration to be in the plasma? Its concentration to be in the tubular fluid compared to the plasma for creatinine? It does not get reabsorbed. Exactly. So it's going to be high. So again, let's say we have a total concentration of 20. So inside we're going to have a concentration of 15 and here 5. So when we divide both of these, we're going to get a value, oops, that is more than 1. Okay, a ratio that is more than 1. Okay, so this is what it's trying to show you here for creatinine. Now let's move on to urea. Urea, basically, it does get reabsorbed. However, it gets reabsorbed later on in the tubular fluid. So at that point, so we saw that water got reabsorbed throughout the tubular fluid, okay? So let's say this is my tubular fluid. So water was being reabsorbed the whole time until at the end of the fluid, we had urea, which was being reabsorbed, okay? So if you came to look at the concentration of urea, you would see that it is higher than the interstitium plasma, okay? So this is why the ratio of urea is more than 1. Okay, now for chloride, I know this one might be a little bit confusing because we talked about how chloride gets reabsorbed and how Yeah, so we had a high concentration of chloride and how it got reabsorbed in the second half of the proximal tubule. But clearly, this graph is telling us that the ratio of chloride is more than one, or slightly more than one. Now, why is that? It's because same logic as urea. So we had our proximal tubule, and we had water reabsorption that was going on the entire way until the end, when we had a high concentration of chloride that started to be reabsorbed. So essentially, even though the chloride was being reabsorbed, when you look at the concentration of chloride towards the end of the tubule, you would find that it is very high. It is higher, not very high, but like it is higher than the concentration in the interstitium. Does that make sense? Sure. Okay. So again, urea, basically, let me try to draw this out. So this is our tubular fluid, okay? And we had a bunch of water that was being reabsorbed the entire time, okay? Now urea, let me do a different color. Urea is green. So this is the entire length of the tubular fluid, okay? And the red is the water. Water was being reabsorbed the entire time. Now, towards the end of the proximal tubule, we had some urea that was being reabsorbed, okay? And this urea was going to enter our interstitium, which is after this. Oh my God, I'm so sorry. Oh, I'm so sorry for my drawing. Uh, Hold on, let me erase this. Okay. Yeah, so the idea that I'm trying to get at here is that urea gets reabsorbed towards the end of the fluid. So when you look at the concentration of urea in the tubular fluid compared to the interstitium, you're going to see that it is still high. And sure, some of it was being reabsorbed, but essentially it's still higher than the interstitium. Does that make sense? Is it clear? Okay. So if you want me to repeat, let me know. So essentially for chloride, it's the same logic behind it. We said that chloride gets oh, yeah, exactly. So it is being reabsorbed, but not as much, but not a lot. Okay, so it's only being reabsorbed slightly. So when you look at the concentration of urea at the end of the tubule, you're going to see that it is still high compared to the interstitium. We're comparing the tubular fluid to the interstitium. Okay? So this is why it's going to be high, because prior to it, we had a lot of water reabsorption. And you know that when water gets reabsorbed, it's going to concentrate the solutes into tubular fluid. So this is why. If you look at the definition also here. So this is when we have a ratio more than one, it's when a solute is reabsorbed less than water, okay? So their reabsorption is less because we have more water that was being reabsorbed. And essentially, it's the same logic for chloride. Chloride is the same thing. Chloride, we said, it gets reabsorbed later in the proximal tubule. So this is this is the entire tubule. So all over time, the water got a lot of time to get reabsorbed until the end when chloride got reabsorbed, only slightly. So when you would come to compare the concentration of chloride in the tubular fluid compared to the interstitium, you would see the chloride concentration is still, it's a bit high. Is that clear? Okay. Also, it took me a while to get this concept down honestly, because it's a bit confusing. You just have to, and you really put your mind into the tubular fluids and everything that's going on in there. Okay, so we're done with creatinine and we're done with urea and chloride. Now let's look at sodium. Okay, sodium over here has a ratio of 1. Now, you might say, Yani, why does it have a ratio of 1? Because we already talked about sodium earlier and we talked about how it gets reabsorbed throughout the proximal tubule. So why does it have a ratio of 1? Does anyone want to guess why? Exactly, yes. So this is a very general rule that you have to apply to whenever you see sodium. So wherever sodium goes, water will always follow it, okay? So, and I have an analogy for you guys actually. So this is my cup, okay? Let's say I have coffee that is filled to the top, and I also have ice that is filled to the top. Now let's say I remove exactly half of the fluid in this cup, and I remove exactly half of the ice in this cup. How do you think my coffee is going to taste? Is it going to be more concentrated, or is it going to be more dilute, or is it going to taste the same? Exactly. It's going to taste the same. So the only difference that we have here is in the volume. So this apply what I just explained to sodium, because whenever sodium gets reabsorbed, it's going to take water along with it. Okay. So this is why when you compare the concentration of sodium in the tubular fluid compared to the interstitium, you're going to find that they're equal. Okay. Is this clear for everyone? Okay. So again, this is everything that I just said in words. So when we have a ratio that is less than one, it means that we're going to have examples of them are glucose and amino acids and bicarbonate. Also, something that I forgot to mention here, if you look back at these lines of bicarbonate and glucose and amino acids, you will see that the line for glucose and amino acids is steeper compared to bicarbonate. And this basically happens because our bodies, they want to reabsorb as much glucose and amino acids as possible. So they're going to try to reabsorb almost all of it, almost 100%. So this is why when you look at the concentration of glucose and amino acids in the tubular fluid, you're going to see that it is almost one. Sorry, it is almost zero. Yeah, it is almost zero because almost all of it gets reabsorbed. However, bicarbonate also does get reabsorbed, but not entirely. Okay, so this is why the lines are different. Okay. Okay, so we talked about this. When we have a ratio more than one, it means that it's urea and chloride, and we said that their concentration is going to rise because water leaves before them. Okay. Now for creatinine, does not get reabsorbed, but it does get secreted very slightly, and because of the water reabsorption, it's going to be the concentration is really going to increase. So you're going to have a ratio that is more than one. Now, when we look at the end of the proximal tubule, so we look at the overall effects that happened over there, we're going to find that about 65% of sodium was reabsorbed with 65% of water. And again, this should make sense to you because, as we said, wherever sodium goes is going to take water along with it. Okay, so the values, the percentages are the same. Then we're also going to have bicarbonate reabsorption and around 85%. This is actually important because I saw a question about it before. I know I just don't want you to miss it because it seems like something that you would overlook, but just remember this value. But 85% of bicarbonate is going to be reabsorbed in the proximal tubule. And then for chloride, around 45% is going to be reabsorbed. And for glucose, amino acids, and organic solutes, about 100% of them are going to be reabsorbed at the end of the proximal tubule. طيب? Now, when we look at the tubular fluid concentration, we're going to look at sodium. And as we mentioned earlier, the ratio is going to be about unchanged. And for bicarbonate, it's going to be less than one, so it's going to be decreased because of the reabsorption. For chloride, as we mentioned, it is going to be increased more than one because, as we said, it gets reabsorbed later on in the tubular fluid. And when we look at inulin, which we have not mentioned at all so far, but basically inulin is a reference parameter, and all you need to know is that it does not get reabsorbed nor secreted. Okay, so it stays constant within the tubular fluid, and what's going to determine its concentration is water reabsorption. So as we know, we have a lot of water reabsorption that's going to happen in the proximal tubule. So this is why when you're going to check the concentration of inulin at the end of the proximal tubule, you're going to see that it has increased by a factor of 3, which is a lot. Okay. So remember this as well. Remember that inulin increases by a factor of 3. What do you mean? Is it the same as creatinine? Sorry, I just saw your question. Creatinine is not reabsorbed at all. It's a substance that does not get reabsorbed, as here we said. It does not get reabsorbed. Okay, so when you're going to look at the concentration, yeah, when we look at the concentration, it's going to be high. This is why the ratio is more than 1 for creatinine. Okay. Okay, sorry about that. So is everything clear so far? Because right now we're going to move on to our next segment, which is the descent. Oh, where is it high for inulin? Okay. So, okay, inulin basically, it's a substance that does not get reabsorbed or secreted. So it's going to stay within the tubular fluid. Now, we said in the proximal tubule, we're going to have a lot of water reabsorption. Okay, so a lot of water is going to go, which is going to increase the concentration of inulin. When you look at the concentration of inulin, you're going to see that it is high. Not the concentration, sorry, I explained that wrong, but basically the ratio of inulin compared to the plasma. Okay, because we have the tubular fluid and then you have the plasma. So when you look at the concentration of inulin in the tubular fluid, you're going to find that it's higher than the concentration of inulin in the plasma. Okay? Because a lot of water is leaving. So if it doesn't get reabsorbed, that means tubular fluid concentration is higher. Yes, exactly. Yes. So we're going to have a high concentration in the plasma because it does not get reabsorbed. Okay? And the reason why it increases is because water is going to leave. So it's going to show as a higher concentration compared to the plasma. Okay? Now, this is also very important. At the end of the tubular fluid of the proximal tubule, we're going to see the tubular fluid is going to be isotonic. And this is because of the water reabsorption that we have that occurs over there. Okay? So we're going to have isotonic fluid. We're going to explain that more in the third lecture. Okay? But just remember that for now. Is everything clear? Okay. So now, good job, guys. We're done with the proximal tubule, which I would say was I feel like the most tense part. Now we're going to move on to the descending limb. Now the descending limb is my favorite because it's literally the easiest one. It has just one function, okay? So the only function of the descending limb of Henle is that it's going to reabsorb water, okay? So when we talk about the descending limb of Henle, there's water reabsorption. That's it. It is impermeable to sodium chloride, so there's not going to be any reabsorption of sodium chloride, and we're only going to be taking in water. Now, okay, so we are in the descending loop, we're taking in water. What do you think is going to happen to the osmolarity of the tubular fluid? Exactly, it's going to increase. So we're going to have a very high, to have an increase in the osmolarity of the tubular fluid. And I put 15% because basically, so remember in the proximal tubule, we mentioned how 65% of the water got reabsorbed. And now it was 15% of the water 15% of the water will get reabsorbed over here in the descending loop of Henle. Okay? So 65% in the proximal tubule. And now over here in the descending limb, we're going to have 15% more of water reabsorption. Okay? So that is it for the descending limb of Henle. Now we're going to move on to the ascending limb of Henle. And the ascending limb, as you can see, it has over here a thin section and over here a thick section, okay? So both of these, they have different channels or transporters. So we're going to talk about both of them separately. But before we get into it, let's talk about the general idea of the ascending loop of Henle, okay? So the ascending loop of Henle, remember, do not forget this, that it is impermeable to water. No matter what happens, it is always going to be impermeable to water, okay? So now what do you think? Okay, it is impermeable to water, and the main job of the ascending loop of Henle is to reabsorb sodium chloride. طيب? Because in the descending loop, we were not reabsorbing sodium chloride, we were only reabsorbing water. So now the concentration of the sodium chloride is going to be high. So this is why we're going to try and reabsorb it in the ascending loop of Henle. So again, high concentration, so we're going to try to reabsorb it. So we have the thin part of the ascending loop, and we have the thick part of the ascending loop, okay? Let's start with the thin part of the ascending loop. Remember, we're trying to reabsorb sodium chloride. In the thin limb, it's very easy. We're just going to reabsorb sodium chloride directly by passive diffusion, okay? So sodium chloride will get reabsorbed by passive diffusion in the thin limb of Henle. Next, for the thick limb of Henle, we're going to have this important transporter called the sodium potassium chloride co-transporter. And what it's going to do basically is that, oops. Okay, so what it's going to do basically is that it's going to take in sodium potassium chloride, right? And what's going to happen is that some of this potassium that is coming inside of the cell is going to back leak outside of the cell. Okay, so this is what's going to happen. We're going to have some of the potassium going outside. Now, the reason why this back leak happens is for two main reasons. Okay, the first one is so that it can keep this channel going. Okay, so we're going to have to keep this channel is going to keep on working. So we're going to keep on getting in sodium and chloride. And the second reason that this potassium is back leaking is to create a positive voltage in the lumen. Okay, now this positive voltage in the lumen is going to act as the driving force to push certain cations paracellularly. Okay, now these cations are going to be pushed paracellularly because of the positive voltage in the lumen created by the potassium backleak. Okay. So again, we have this sodium potassium chloride co-transporter. They're going to bring in sodium chloride potassium. Sodium is going to leave through the sodium potassium ATPase. Potassium and chloride, they're going to leave through a chloride potassium channel together. And then potassium is going to backleak and it's going to cause the function of this channel to always be working. And it's also going to cause, most importantly, a positive voltage in the lumen. Okay, now this positive voltage is going to cause, or it's going to push these cations to be reabsorbed paracellularly. Of these, we have potassium, sodium, magnesium, and calcium. Remember magnesium and calcium because we're going to see them later on. So again, remember magnesium, calcium. Okay, they're going to be reabsorbed paracellularly because of the potassium backleak. Now, another transporter that we see over here is the sodium H plus antiporter, which, if you remember, we mentioned that in the proximal tubule, we said that it is used to indirectly reabsorb bicarbonate. So I did not include the exact steps of how this happens because I already mentioned there. But it's basically the exact same process. So we're going to have the formation of carbonic anhydrase and carbon dioxide and water, and they're going to come into the cell. And then with the help of carbonic anhydrase, we're going to form carbonic acid, and then we're going to reabsorb bicarbonate. So it's the exact same process as the proximal tubule. So essentially, we're just going to have bicarbonate reabsorption over here. Okay. Now, I know it looks like there's a lot, but guys, I promise just with repetition, it's going to stick more, inshallah. Okay. So again, we have the potassium recycling, and the function of it is to provide potassium for this channel, co-transporter, and it's also going to provide a positive voltage in the lumen, which is going to push these ions to get reabsorbed. Of those, we have calcium and magnesium. Now, we're having a lot of solute reabsorption in the thick ascending loop of Henle, as you can see. So what do you think is going to happen to the osmolarity of this area? Decrease, exactly. So the osmolarity is going to decrease. And actually, another name for this segment is the diluting segment. And this is because the tubular fluid gets very, very dilute over here. So yeah, that is it for this slide, actually. So yeah, the osmolarity will decrease, and it's called the diluting segment. And we have all of these channels. If you guys need me to repeat anything, please let me know. Okay, so this is everything that I just explained. Let me erase this. I don't know why it's still here. Okay, this is everything that I've just explained in words. So again, the thin ascending limb is going to reabsorb sodium chloride by passive diffusion, and the thick ascending limb is going to reabsorb sodium chloride via the potassium chloride co-transporter, and then there's going to be a potassium recycling, which is going to cause or create a positive lumen voltage, and this voltage is going to cause the paracellular reabsorption of these cations, which are magnesium, calcium, sodium, and potassium, mainly magnesium and calcium. Okay? And the thick ascending limb, or TAL, is also known as the diluting segment. طيب. Now let's look at calcium reabsorption because it occurs in the proximal tubule and also the thick ascending limb of Henle. So overall, the calcium reabsorption is going to happen in the proximal tubule, in the thick ascending limb, in the distal tubule, and a little bit in the collecting duct. And the way calcium gets... Oh, can you explain dilution again? Okay, sure. So we said over here that the ascending limb is impermeable to water, okay? So water is going to stay within the tubular fluid, طيب? And as you can see, we have a bunch of different channels, and all of these, they're going to take in solutes. So we're going to have a lot of solute reabsorption. So eventually, the tubular fluid is going to become more dilute, and when we say more dilute, it means that we have less solutes within a substance. So this is going to basically decrease the osmolarity. So this is why it is called the diluting segment. Okay. Okay, so for calcium reabsorption, it occurs through two main pathways. The first one is the paracellular, and then we also have transcellular. So before I get into them in details, I already mentioned like two ways that calcium gets reabsorbed paracellularly. Does anyone remember what they are? We just mentioned one right now, and also one earlier. Solvent drag, exactly, that's very good, yes. What about the other one? Backleak, exactly, good job. So both, I'm actually really happy. Thank you guys. So both for the paracellular pathway, the first one is the solvent drag. Okay, so as we said, when water gets reabsorbed paracellularly, it's going to drag some ions with it. And of those, we have calcium. طيب. Now, the second way that this can happen is by the potassium backleak, as we explained earlier. This is going to cause a positive voltage, which is going to push the calcium reabsorption in between the cells. طيب. And the proximal tubule is going to reabsorb 70% of the calcium, which is okay, so we can say the bulk of calcium is reabsorbed into the proximal tubule. And we have 20% that gets reabsorbed in the thick ascending limb of Henle. Now, when we talk about the transcellular pathway, it basically occurs in the distal tubule, which we did not get into yet, but we will. So there's also going to be calcium reabsorption in the distal tubule that is going to occur through the transcellular pathway. Now, basically, what we're going to see here is that we're going to see calcium channels. Okay, they're going to take in calcium, and then they're going to excrete them, not excrete. Sorry, they're going to take in calcium, and they're going to take them to the blood through either a calcium ATPase or a calcium sodium channel. Now, the important thing here that you need to know is that we have a hormone called PTH, or parathyroid hormone. Now, this hormone, what is it going to do? Is it's going to increase the calcium reabsorption. Okay. Now, this is very important. So when we talk about PTH, we're talking about increased calcium reabsorption, okay? So again, calcium reabsorption paracellularly, it occurs through solvent drag, and then also the positive voltage in the lumen caused by potassium backleak. And then transcellularly, it's just a calcium channel, and it's going to be increased by PTH, okay? So again, this is everything that I said in words. Now we're going to talk about magnesium reabsorption. So magnesium reabsorption, we also saw it in solvent drag and also in the potassium backleak, but we're not going to mention the solvent drag because that was only a very minor amount of magnesium that was reabsorbed through that pathway. So when we talk about magnesium reabsorption, just think about the potassium backleak that creates a positive voltage that is going to push magnesium to be reabsorbed paracellularly, okay? Because this is the main area for magnesium reabsorption, okay? So again, magnesium reabsorption will occur in the thick ascending limb of Henle because of the potassium backleak, okay? So we have reached our second checkpoint. Is everything clear? Do you guys need me to repeat anything? So most of calcium is transferred. Yes, exactly. That's a very good point. So over here, someone said that most of the calcium reabsorption occurs in the proximal tubule through the solvent drag, which is very true. And most of the magnesium reabsorption will occur through the potassium backleak. Yes, you're right, Noor. Okay. Should we move on to the next part? Okay. So now we're done with the thick ascending limb of Henle, and we're going to move on to the distal tubule. Now, the distal tubule, basically, it's again divided into two parts. So we have the early part of the distal tubule, and we're going to have the late part of the distal tubule. The early part, we're going to cover it separately, while the late part, we're going to cover it with the collecting duct, because the late part of the distal tubule and the collecting duct, they basically have similar channels and similar functions, so they're going to be grouped together. And then we're going to start with the early distal tubule. So let's see that. So again, this is the early distal tubule, and it's very, very easy and direct. So again, in the early distal tubule, we are still impermeable to water. طيب? We are still very much impermeable to water, and our main goal is again to just reabsorb sodium chloride. So we want sodium chloride, so we're going to get a sodium chloride channel. It's very direct. We have just one sodium chloride channel. Sodium is going to exit through a sodium potassium ATPase, and chloride is going to exit through its own chloride channel. That's it. So again, early distal tubule, it's impermeable to water, and we're just going to reabsorb sodium chloride. Now, what do you think will happen to the osmolarity of the tubular fluid? Because we said in the ascending loop it was low. So what do you think is going to happen here? Yes, so it's going to get even lower actually, because we're still impermeable to water, and we're absorbing even more solutes. So the osmolarity is going to get even lower than previously. Okay, so that is it for the early distal tubule. Next, we're going to go into the late distal tubule and the collecting duct. Now, this part over here is so high yield because we have a lot of hormones that are going to act on this area specifically. So I really need you guys to focus with me here and just remember what I'm telling you, because everything here is going to be high yield. Okay. So in this area, we have two types of cells. The first ones are the principal cells, and then we also have intercalated cells. Okay. Now, the first thing that we're going to see in the principal cells is a sodium channel and a potassium channel. Okay. Before I get into them, I'm going to talk about the sodium potassium ATPase. Now, this ATPase, I know we have talked about it. I'm so sorry, my brother keeps knocking. 1 second. Okay, I'm very sorry for all the interruptions. Can you explain before why osmolarity is low? Okay, so you mean from the ascending limb of Henle? From this part? This one or after? Oh, okay. So the early distal tubule. Okay. So we said, okay, in the ascending limb of Henle, we said that we were impermeable to water. So basically, water is going to stay inside of the tubule, and we're going to get reabsorption of sodium chloride or solutes. طيب? So when we get reabsorption of solutes, this means that the tubular fluid is going to become more dilute. So the osmolarity is going to decrease because we have less solutes. Basically, think of osmolarity as solutes. Okay, so when you have a lot of solutes, it's going to be high osmolarity. And when you have low solutes, it's going to be hypoosmolar. طيب? So that was the case that we saw in the ascending loop of Henle. Now the case is very similar here. It's the same thing. So in the early distal tubule, we are still impermeable to water, and we're still taking in sodium chloride. Okay, so because we're impermeable to water, so there's going to be more water into the tubules, and we're going to take away more solutes. So that means that not a lot of solutes are going to be left inside of the tubular fluid. Okay, so we're going to get even a lower osmolarity compared to previously. Does that make sense to you? Basically, osmolarity is the amount of solutes that we have. So far, we've seen that in the ascending loop and the early distal tubule, we've only had sodium chloride reabsorption. So this is why we are taking in sodium solutes. Yeah, exactly. We have less solutes in the tubular fluid, so this means that the osmolarity is going to decrease. Does that make sense? Do you want me to repeat? Low solute basically means low osmolarity. High solutes basically means high osmolality. Okay? And when we have water that is more present in the tubular fluids, it's going to dilute those solutes, so we're going to have a low osmolality. Does that make sense? Okay. So again, when we're talking about the late distal tubule and collecting duct, we're going to see this sodium potassium ATPase. Now, this sodium potassium ATPase, I know we've seen it like in almost every segment of the nephron, but here particularly it's going to be very important because, as we mentioned earlier, its job is to create an electrochemical gradient for secondary active transporters to work, basically. And over here, basically, it's going to make sure that the sodium concentration inside of the cell is low by taking it out. So as soon as sodium comes in, is going to take it off the cell so that we have more sodium inside of the cell, and the high sodium here is going to push the sodium to come inside of the cell because we have a low concentration of sodium here. Okay, and this ATPase, what is it going to do as well? It's going to take the potassium from the blood and take it inside of the cells so that potassium can get secreted. Okay, so this is a very, very important function of the principal cells. When I say principal cells, always remember sodium reabsorption and potassium secretion. And we have more. I'm just going to get into it in a minute. So sodium reabsorption and potassium secretion. Okay? Now, something else that we see in the principal cells is that because sodium gets reabsorbed, it's going to cause the lumen voltage to become negative, okay, because sodium is positive, so it's going to cause the voltage of the lumen to become negative. Now, this negative charge is going to repel chloride to get reabsorbed paracellularly, okay, so sodium is going to push chloride, sorry, not sodium, the negative voltage of the lumen is going to push chloride to get reabsorbed paracellularly, okay? So this is something else that we see, sodium chloride reabsorption in the principal cells. And then something else that we see in the principal cells is water reabsorption. Now, this water reabsorption only occurs if we have a specific hormone called ADH. We're going to be talking about this a lot in the third lecture, but just have an idea of it right now. So we're going to have a water reabsorption in the principal cells only if ADH is present, okay? So again, when I talk about the principal cells, I want you to remember four things. We're going to have sodium chloride reabsorption, water reabsorption, and potassium secretion. Okay, again, sodium chloride reabsorption, water reabsorption, depending on ADH, obviously, and potassium secretion. The main ones are sodium reabsorption and potassium secretion. Those are so important. No, not really. The potassium, when it goes out, when it secretes, it does not really affect the charge. I know it does not really make sense, but you don't need to go into the actual details of it. Just know that sodium is going to affect the charge, but potassium, because it's pretty minimal, so it's not going to affect the charge. There's a whole reason behind it, but I just don't want to complicate it. So just know sodium is going to affect the charge, okay? And it's going to cause a negative lumen, negative voltage of the lumen. So we talked about our principal cells. Now we're going to move on to our intercalated cells. And now when I talk about the intercalated cells, again, I want you to remember two main things. We're going to have H plus secretion and potassium reabsorption. Okay, so these are so important. H plus secretion and potassium reabsorption. Okay. Okay, so another idea that I want you to keep in mind right now is, it's not going to make sense right now, but just keep it in mind because we're going to see it later, is that H plus, as we know, is an acid. طيب. So now if it's going to be higher in our body, it's going to go through these channels. طيب. It's going to be secreted through these channels. Okay. Yeah, so I'm going to explain this later on. So yeah, just keep in mind that H plus is an acid and then it can get affected in this area in the intercalated cells. So again, why is this? Okay. Before we move on, principal cells, again, they are responsible for sodium reabsorption, chloride reabsorption, potassium secretion, okay? Intercalated cells, H plus secretion and potassium reabsorption, okay? So this is everything that I just said in words. Again, principal cells, we have sodium chloride reabsorption in water, and they also secrete potassium. And then the intercalated cells, they're going to secrete H plus and they're going to reabsorb potassium, okay? So the text is everything that I've just explained, by the way. This is a summary of all the channels that I just talked about because I know there are a lot. So I really recommend you go through this at the end of your studying, just as a quick review, because it puts everything together. Okay. So before we move on to our next section, because we're actually done with all of the channels and transporters in the nephron, is everything clear? Do you guys want me to repeat anything? Names of the channels, like which ones? The aquaporin, listen, the only reason I included them in the notes section here is because the doctor put them in your notes section, but you do not need to know the numbers, no. Just know that water goes through aquaporin channels. That's it. Don't know the numbers. He's not going to ask you about the numbers. It's very low yield. Okay. Okay, let's move on to our next section, which is hormonal regulation. So basically, we're going to talk about some specific hormones that are going to affect the changes that we see with sodium, potassium, and calcium. Okay, we're going to start with sodium and calcium. And potassium, not calcium. So the first hormone that we're going to see is aldosterone. Now, aldosterone, it acts on principal cells, which are present, as we just mentioned right now, that they're present in the late distal tubule and collecting duct. Now, can anyone remind me what are the functions of principal cells? What do they do exactly? Exactly, that's very good. So they're responsible for sodium reabsorption and potassium secretion. Okay, and the way aldosterone is going to increase basically aldosterone is going to act on the principal cells to increase sodium reabsorption and potassium secretion. Now, the way it does that is through four main mechanisms. Okay, the first one is that it's going to increase the number of sodium channels and increase the activity of the sodium channels, and then it's going to increase the sodium potassium ATPase pump and also increase the production of ATP, which is going to stimulate the pump. We're going to look into it right now, so I know this might be a bit like confusing. So let's look the mechanism behind how aldosterone does all of this to increase sodium reabsorption and potassium secretion. So we have our cell. We are in the late distal tubule and the collecting duct. This is everything that we have seen so far, except okay, the inside of the cell. So we have our hormone called aldosterone, A for aldosterone. So aldosterone, what's going to happen is it's going to come inside of the cell. It's going to bind to its mineralocorticoid receptor. Right? Once it binds to its mineralocorticoid receptor, it's going to enter the nucleus of the cell and it's going to go, do transcription. So we're going to have mRNA. Now this mRNA is going to leave the nucleus, enter the cytoplasm, and go undergo translation. So we're going to have protein synthesis. Okay, these are all like very small details. So we're going to have protein synthesis. Now, what this protein synthesis is going to do is going to show the actions of aldosterone. So it's going to act on the channels of sodium to increase their numbers and their activity. Okay. Then it's also going to act on the sodium potassium ATPase pumps. So it's going to increase the numbers of these pumps, and it's also going to stimulate the mitochondria. And we know that mitochondria makes ATP. So we're going to have formation of ATP. Now, what's going to happen when all of this happens? Say Bismillah, because okay, jump scare. So we're going to have increased number of sodium channels, okay, because we said the protein synthesis is going to increase the sodium channels and it's going to increase their activity. And then we're also going to have an increase in the sodium potassium ATPases. Now, when we have more of these ATPases, if you recall what I explained earlier, we said that when we have more ATPase, so basically these channels are going to come, sodium is going to come more, so it's going to go to or leave the cell through this ATPase, and for this ATPase to work, it's going to take in more potassium inside of the cell, okay? Because it needs to take out the excess sodium, because now we have a lot more sodium coming in, okay? So now all that sodium that is coming in, to compensate for it, we need even more sodium potassium ATPases. So the sodium potassium ATPases are going to increase, so to take out all of that excess sodium, and to compensate for it, we're going to remove even more potassium from the blood. Now, okay, we have even more potassium in our blood, in our cell now, okay? So we have high levels of potassium. What's going to happen? This is going to cause an increase in the potassium channels because we need to remove those high levels of potassium that came from the blood, okay? So we're going to have an increase in the potassium channels. And something else is going to happen is that, as we said, when sodium gets inside of the cell, it's going to cause a negative voltage of the lumen, which is going to push chloride reabsorption. But now we have a lot more sodium reabsorption happening, okay? So this is going to cause an even greater negative lumen. So this high lumen, greater negative voltage is going to cause an even greater push of chloride to go get reabsorbed paracellularly. Okay, so we're going to have even more chloride reabsorbed. Okay. I know this seems very confusing, but it's actually, it all just makes sense when you connect everything. Everything is just interconnected. Yeah, I'm going to repeat this part, don't worry. I'm just going to finish till the end. No, actually, let me just leave this for later. Okay, so what did we say? We said we have our hormone, aldosterone. Okay, aldosterone is going to come. It's going to bind to our mineralocorticoid receptor. Then this receptor is going to go inside of the nucleus to form an mRNA. Now this mRNA is going to leave the cell, the nucleus. It's going to undergo protein synthesis, and then this protein synthesis is going to do the actions that we wanted from aldosterone. So it's going to, what did we say? We said we want to increase the number and the activity of the sodium channels, and we also want to increase the number and the activity of the sodium potassium ATPases. Okay, so we're going to have an increase in the sodium channels, an increase in the number of the sodium channels. And then we're also going to have an increase in the number of these sodium potassium ATPases. Now, we said that the function of this channel, this ATPase, is, okay, before I go there, so we said that we have more sodium coming in because we have more sodium channels, so we have a lot of sodium coming inside of the cell. So to keep the gradient or to keep the concentration of the sodium low inside of the cell, this sodium potassium ATPase is going to work even more, and it's going to increase because it wants to take out all of that extra sodium. Okay, so we're going to have more sodium that is going to come out of the cell, and because of that, to compensate for it, because this is a sodium potassium ATPase. So for this to work, potassium needs to also go in. Okay, so we're going to take more potassium from the blood, and it's going to enter the cell. So more potassium is going to leave the blood, and it's going to enter the cell, and then eventually, because we have a lot of potassium inside of the cell, this is going to indirectly cause the increase of the potassium channels. So you're going to have more potassium channels in order to remove all that potassium. And as we said earlier, that when sodium gets reabsorbed, it's going to create a negative voltage in the lumen. So now what happens if we have more sodium reabsorbed? It's going to create an even greater negative voltage in the lumen. Okay, so we're going to have a very negative voltage in the lumen. Now this great negative voltage is going to push even more chloride to be reabsorbed paracellularly. Okay, so essentially we're going to have increased sodium reabsorption, increased potassium secretion, increased chloride reabsorption. Okay, all of these. Now, this is for the principal cells. I know we said that aldosterone, as I said here, is going to act on the principal cells, but there's an extra effect that it has on the intercalated cells, and I'm only mentioning it because the doctor mentions it later. And I just don't want you guys to get confused. So aldosterone is also going to increase the H plus secretion. Okay, just notice. Aldosterone is going to increase the H plus secretion, and when you're losing more H plus, just know that because H plus is acidic, so when we're losing more acid, we're going to become alkaline. I will mention this again later, so if it doesn't make sense, that's okay. But essentially, the net effect of aldosterone is that we're going to have more sodium reabsorption, more potassium secretion, more chloride reabsorption, and more water reabsorption. And then also H plus secretion increases. Do you want me to repeat this part? I know the way it happens can be a bit confusing because of all the arrows and all the channels and everything, but essentially just know that it's going to increase the sodium. No, we did not mention water reabsorption, but it does have an effect on water reabsorption. Because again, we're reabsorbing more water. So remember what we said, that wherever water goes, water is going to follow it. That was a good catch. Thank you. I forgot to mention that. But yes, so aldosterone will cause an increase in the water reabsorption, but that's because sodium is being reabsorbed more. So it's going to pull with it water. Okay? Okay. So these are the effects of aldosterone. Now we have angiotensin 2. Angiotensin 2, I'm not going to go too much into detail about it because I believe you will be taking it more in another lecture called regulation of volume, because you guys were not introduced to the RAS system yet, I believe. But just basically what you should know from angiotensin 2 is that it's going to increase the sodium water reabsorption, and it's also going to stimulate aldosterone, which is going to cause even more greater water and potassium secretion. So aldosterone. Yeah, exactly. Aldosterone is just basically going to stimulate everything that happens in the late distal tubule and the collecting duct. I like how the way you summarize things. It's very good. Okay, now we have another graph over here, and angiotensin 2. Yeah. So basically, angiotensin 2 is going to stimulate aldosterone. So you're going to have all the effect of aldosterone, and then you're also going to have even more effect because angiotensin 2 also causes the sodium and water reabsorption. Again, I don't want to go too much into detail about this one because you're going to take it in another lecture. But essentially, just know the effects. That it's going to cause the aldosterone effect and even more sodium and water reabsorption. Is that clear? Okay. Now we have this graph over here, and basically what it's showing us is the plasma aldosterone concentration compared to the number of open channels. Now we literally just mentioned this right now. We said that aldosterone is going to increase the number of sodium channels and also increase and stimulate their activity. Okay, so this graph is essentially just telling you that. It's telling you that the more aldosterone concentration increases, the more the number of the sodium channels are going to increase. Okay, so it's very simple, very direct. Now this other graph is basically showing us the concentration of plasma potassium concentration compared to the plasma aldosterone concentration. So let's think about it. Let's say in our body we have a lot of potassium, okay? We have too much potassium, and obviously whenever we have too much of something, our body wants to get rid of it. So the way we get rid of potassium, as mentioned earlier, aldosterone is going to increase the potassium secretion. So it makes sense when we have high plasma potassium concentration, we're going to have a high aldosterone concentration to try to secrete all that excess potassium. So eventually, we're going to have a normalized potassium in the plasma. Does that make sense? Okay. Yeah, so I just wanted to remind you again. So we have increased potassium. So this is what's going to happen. Aldosterone is going to increase the potassium. So this is why a high plasma concentration of potassium will increase aldosterone. Now let's talk about urine potassium excretion. So the way potassium is excreted, potassium excretion depends on two things. One of them we have already mentioned, which is aldosterone. We said that when aldosterone is secreted, it's going to cause an increase in the potassium secretion. Okay? Now the other part is the high plasma potassium concentration, which we low-key already touched upon it earlier. So we said that when our body has a lot of plasma concentration, a lot of plasma potassium concentration, it's going to want to excrete it. So whenever we have a high potassium concentration, where the excretion of potassium is also going to increase. Okay, so we're going to increase to excrete the excessive potassium. Okay, so urine potassium concentration depends on aldosterone and the plasma potassium concentration. Okay? So this graph is showing you the same thing that I just said. So when aldosterone increases, the urine potassium excretion is going to increase because it's going to increase the secretion of potassium. And then when the plasma potassium concentration is going to increase, it's also going to increase the plasma potassium, sorry, not the plasma. When the plasma potassium concentration, sorry, all these words are getting a bit jumbled up, but basically the idea is very simple. When you have a high plasma potassium concentration, you're going to have a high urine potassium excretion, a higher potassium excretion, because you want to get rid of that potassium. Okay, very simple. Now we have reached our last checkpoint before we finish these two lectures. Do you guys want me to repeat anything, or is everything clear? The red curve? Okay. So, okay, the green curve over here is just showing the relationship between the aldosterone and the potassium secretion, okay, which we have already talked about. We said that aldosterone is going to increase the potassium secretion, which is going to increase the excretion. Now, for the red curve, it's the same thing as well. So it's basically telling us, look at the red text over here. It's showing us the relationship between the plasma potassium concentration compared to the plasma, sorry, not the plasma potassium concentration compared to the urine potassium excretion. Okay, so the more potassium that we have in our bodies, the more that we want to excrete it because it's too much. Okay, when we have too much of something, we want to get rid of it. We want to remove the extra. So this is why the excretion is going the shape of the graph. You don't need to know the exact shape of the graph. Just know that when this increases, this is going to increase. This is the way the doctor explained it as well. You don't need to know why these shapes are different. Just know that they're going to increase. Yeah, I get you. But you don't need to know the exact detail. Just know that they're both going to increase. When the plasma potassium concentration is higher, the excretion is also going to be higher. Okay? صراحة يعني I'll be honest with you, I'm not sure about that because it was not emphasized. So I would say يعني I could get back to you about that later on, inshallah, but I'm not sure about that, if which one has a higher effect. Because it's mentioned that both of them, they have an effect on the urine potassium excretion. But I get your point, yeah. Okay. So, okay, for this slide, I'm not going to go over it because I watched your recording actually, and the doctor did not even go over this. It was not even present in his slides. And when he sent you his slides, there were no notes under. So I'm not going to go over this slide. I did write some notes on the side if you guys want to refer back to them. But I'm pretty sure the doctor is not going to ask you about anything about here because he did not even explain it. Okay. So I just included it for completion's sake. Now we're going to look about the potassium transport across a nephron depending on our diet. Okay, so let's say we're taking a low potassium diet. Okay, so that means that we're going to try and retain as much potassium as we want because we're not taking a lot of potassium, so we're going to try and save it. Okay, so as you can see over here in the tubule, we're going to have reabsorption throughout the nephron. So we're going to have reabsorption in the proximal tubule, in the thick ascending limb, the distal tubule, and also in the in the collecting duct. Now compare this to a person who has a normal to high potassium diet, okay? Now when someone is taking too much potassium, as we said, we want to excrete or secrete the extra potassium. So this is why you're going to see secretion happening in the late distal part of the tubule and in the collecting ducts, okay? So the reabsorption is going to stay constant prior to the distal tubule, but then after that, as we mentioned, we have, as we mentioned, we have potassium secretion happening in the late distal tubule and collecting duct. So we're going to have higher secretion in this part to try and get rid of the excess potassium. So this was just building on to what we previously learned. Okay. Now let's look at potassium balance. So as you can see from these happy and sad faces, we need to have a normal balance of potassium in order to be healthy in our body. And the normal range is from 3.5 to 5, okay? Lower than 3.5 is going to be hypokalemia, and higher than 5 is going to be hyperkalemia. I'm not going to go into detail for each of these diseases. I'm just going to explain the main idea of how these can cause hypokalemia, because again, this is too advanced for you and you're not going to be asked about the specific disease, but you will be asked about the mechanism. So starting with the causes of hypokalemia, we have diarrhea and vomiting. So starting off with diarrhea. Diarrhea causes hypokalemia because we are directly losing potassium, okay? So when we're directly losing potassium, obviously this is going to bring us into a state of hypokalemia. Right? Next, we have vomiting. So can anyone tell me what happens in vomiting? Like, what are you vomiting exactly? What content are you vomiting exactly? Yeah, and the stomach content, it's acidic, correct? So you're losing acid by vomiting. So when you're losing acid, this means that you're going to become in a state of alkalosis. Yeah, as HCl, yeah, which is acid, basically. And my main point is that we're losing acid. So when we lose acid, we're going to become in a state of alkalosis. And to understand the mechanism of how alkalosis causes hypokalemia, we have to go back to our late distal tubule and collecting duct, okay? So we mentioned here that there is this potassium H plus ATPase channel. طيب? Now let's say we are in a state again of alkalosis, meaning we do not have a lot of H plus ions. So if you look inside of the cell, we're going to have low H plus ions, okay? Now, if we have low H plus ions, this means that less H plus ions are going to be able to leave the cell, and this pump is not going to be able to work, so less potassium is going to come in. طيب? Now, we're going to have less potassium coming in, which is going to bring us into a state of hypokalemia. Does that make sense? So we just have less H plus ions. So less H plus ions are going to make this pump work. So we're going to take out less H plus, and less potassium is going to come back in. So this is how alkalosis can cause hypokalemia. Is that clear? Yes, exactly, because we do not have H plus, because H plus is acidic, okay? And when we're vomiting acidic content. So we're basically losing a lot of acid, which would put us in an alkalotic state, okay? And when we're in an alkalotic state, it means that we do not have a lot of H plus, so less H plus can be secreted, less potassium can come back in, okay? Another cause for hypokalemia is that when the kidneys lose too much potassium. So the first one is when we have increased aldosterone activity. And this should make sense to you because we said aldosterone is going to overall increase the secretion of potassium. Okay. So when we have too much aldosterone, like in a condition called hyperaldosteronism, it means that we're producing too much aldosterone. So we're going to be secreting too much potassium. So we will be losing a lot of potassium. And this is going to bring us into a state of hypokalemia. Okay. Now, another cause of how kidneys can lose too much potassium is when we have increased distal sodium delivery. Let me explain this. So, we said that the sodium potassium pump is very important and it depends on the concentration of sodium. So, when we have, let's say, when we have more sodium coming in from the tubular fluid, this means that more sodium is going to come in and this pump is going to work even harder to remove that sodium that is inside to the blood. Okay, so we're going to have this pump working even more. Now, for this pump to be working even more, it means that it's going to take more potassium from the blood to be able to bring it inside of the cell and then secrete it. So essentially, we're going to have more potassium secretion. Okay, so again, we have more sodium present in the tubular fluid, so it's going to come inside, and now we're going to have high concentration of sodium inside of the cell. To get rid of that extra sodium, this pump is going to work even more. So, what do you mean both? You mean the ATPase and the potassium channel? So yeah, basically, yeah. So you have more sodium inside. You have more sodium in the tubular fluid. So more sodium is going to come in. This pump is going to work even more. It's going to bring in order to decrease the sodium concentration that is going to be inside of the cell. And for this pump to be working more, we need to take out more potassium from the blood and bring it out into the tubular fluid. So more potassium is going to be secreted. Does that make sense? So we're going to have increased potassium secretion and also increased sodium reabsorption because of the increased distal sodium presence. We're going to have more sodium delivery. Okay, so this is going to increase this, and then increase this. So more potassium secretion. Yes. And then we have alkalosis, which we already mentioned, which is when we have less potassium reabsorbed because we have less H plus present in our body. So this pump is not going to be able to work well, which is going to cause alkalosis. Okay. Now that's it for the hypokalemia causes. Now let's move on to hyperkalemia. Hyperkalemia, we have cell shift. So we know that inside our cells, we have high levels of potassium. So when we have a disease, a specific disease that is causing these cells to burst, or a lot of cells in our body to burst, this means that the potassium inside of our cells is going to get excreted. Sorry, not excreted, it's going to enter the plasma. So we're going to have potassium leaving the cells. So essentially, we're going to be hyperkalemic. Okay? So more potassium is going to leave the cells. So we're going to have high potassium in our blood, leading to hyperkalemia. Okay. Now, another cause for hyperkalemia is when the kidneys, they fail to excrete potassium. And it's basically the opposite of what I just explained. So in hypokalemia, we talked about how too much aldosterone and too much sodium delivery can cause hypokalemia. But now here we're saying low aldosterone because we said that aldosterone causes secretion of potassium. So if we have low aldosterone, we're going to have hyperkalemia. And same thing for sodium delivery. When we have lower sodium that is being delivered to the late distal tubule and collecting duct, we're going to have lower potassium secretion. Same mechanism that I explained earlier. Okay. Then we have also acidosis because alkalosis was for hypokalemia. Now acidosis is for hyperkalemia. Okay. And the way acidosis works is again, so we're in a state of acidosis, meaning we have a lot of H plus ions because H plus ions are the acids. Okay. Now let's say we have a lot of H plus ions. So this pump is going to work even more, and even this ATPase. So we're going to have to bring a lot more H plus ions to the outside in the tubular fluid. And for this pump to work, this means that we're going to take in more to reabsorb more potassium. Okay, so we're going to be taking in more potassium and we're going to be secreting more H plus. So eventually the potassium is going to be reabsorbed and this is going to put us in a state of hyperkalemia. Does this all make sense to you guys? Do you want me to repeat anything? Okay. So now we're done with potassium balance, alhamdulillah. We're going to move on with our last ion, which is calcium. So now we're going to talk about calcium balance. So as you can see over here, we have calcium reabsorption in the proximal tubule, in the thick ascending limb, in the distal tubule, and in the collecting duct. Okay. Now calcium can actually be regulated by 3 hormones. One of them we mentioned it earlier, which was PTH. Then we also have vitamin D, and we also have calcitonin. Now, I kind of gave you guys like a spoiler alert by coloring them into green and red to tell you guys which ones are going to increase and which ones are going to decrease. So PTH and vitamin D, they're basically going to increase the calcium reabsorption or the calcium levels in our blood, while calcitonin is going to decrease the calcium levels in our blood. Okay, now let's look into each of these separately. So we have PTH. PTH, we already mentioned it when we talked about calcium reabsorption. We talked about how calcium, when it gets reabsorbed transcellularly and in the distal tubule, it's going to have calcium channels to go in. Now, PTH actually affects these calcium channels and it's going to increase the reabsorption of these calcium channels. Okay, so this is how PTH is going to work. So the net effect of of PTH is that it's going to raise the blood calcium. Okay, so PTH is going to increase reabsorption of calcium. And then we have vitamin D, which is also known as calcitriol. Do not forget this name, okay? Calcitriol or vitamin D. So vitamin D actually has effects on 3 main organs. So the first one is the intestine, then we have the kidneys and the bones, okay? So the way it's going to work in the intestine is that it's going to increase the calcium absorption in the intestines, and then it's also going to increase the calcium reabsorption in the kidney. You don't need to know the exact mechanism of how it does that, but just know that it increases the calcium reabsorption in the kidney. And then it's also going to help deposit calcium in the bones. Now, some of you might say that this mechanism it's supposedly going to decrease the calcium in the blood because, you know, we're depositing calcium in the bone. But that's not true, and that's not the case because it only takes the excess calcium that is in the blood. So it does not take from any normal values. So whenever we have extra calcium in our blood, vitamin D is going to take it and deposit it in the bone. So when you look at the net effect of all of these changes happening, you're going to see that we have a raise in the blood calcium levels. So we're going to have an increase in the calcium levels because of vitamin D. Okay. Now our last hormone is calcitonin. And do not let the name fool you, because I know when you hear calcitonin, you might think that it's going to, increase calcitonin, but that's the opposite. Calcitonin is actually going to lower the levels of the calcium in the blood, and it does that by stimulating calcium excretion. And that is it, actually. And it comes from the C cells of the thyroid gland, calcitonin. Okay, that's it for the calcium balance. Now we're going to go into one final thing of the tubular functions lecture, which is a clinical disease. Before that, does anyone have any questions, or if there's anything that's not clear, please let me know. I would be more than happy to repeat. Oops. Okay, it's clear. Thank you so much. Okay, so now let's move on to our disease. So we have something known as the mineralocorticoid excess syndrome. So what's going to happen here? Basically, in our bodies, we have steroid hormones, and of those, we have aldosterone and cortisol. Okay, now aldosterone comes inside of the cell. We already talked about aldosterone. It's going to come inside of the cell and it's going to bind to its mineralocorticoid receptor. Okay, now cortisol is also going to come and it's going to bind to its glucocorticoid receptor. Now, what happens is that basically in our bodies, we have high levels of cortisol, like way higher than aldosterone. Okay, so basically, if nothing stops cortisol, it's because of its high concentrations, it can basically go and bind to the mineralocorticoid receptor and it can induce the effects of aldosterone. Right? So to prevent that, thankfully our bodies, alhamdulillah, they have this protective mechanism, which is an enzyme called 11-beta hydroxysteroid dehydrogenase. I know the name is horrible, but this is the enzyme name, and it's going to protect us by converting the excess cortisol into an inactive metabolite known as cortisone. Okay, so now that we have this inactive metabolite, it is not going to be able to bind to the mineralocorticoid receptor. So let me repeat that again. So in our bodies, we have aldosterone and cortisol. These steroid hormones, they are actually structurally similar. Okay, so this is why this is a problem. So aldosterone is going to come and it's going to bind to the mineralocorticoid receptor. Cortisol is going to come and it's going to bind to its glucocorticoid receptor. Now, in our bodies, we have higher levels of cortisol compared to aldosterone. So what can happen is that if nothing stops this high cortisol, it can go and bind to our mineralocorticoid receptor and induce the effects of aldosterone because they're both structurally similar. Okay, and we don't want those effects to come because they're going to be very excessive. Like imagine we're going to have a lot of sodium retention, a lot of potassium secretion, and all of those unwanted effects. They're going to happen at an excess. Okay, so to prevent that from happening, we have this protective enzyme called 11-beta hydroxysteroid dehydrogenase. What this enzyme does is it's going to convert this excessive cortisol into an inactive metabolite called cortisone. Now, what happens when we have this enzyme? Something happens to this enzyme. So let's say we're eating something that is going to inhibit this enzyme. So when this enzyme does not work, the excessive cortisol is going to come and it's going to bind to its glucocorticoid receptor. Also, it's going to come and bind to the mineralocorticoid receptor. So we're going to have the unwanted effects that we didn't want in the beginning. So we're going to have excessive effects of the aldosterone. So increased sodium retention, increased potassium secretion, water retention. Okay. Now, an example of what can inhibit this enzyme is the licorice. Okay. Now, this is the text form of everything I've just said. Let's just go over it quickly. So, in our bodies, cortisol levels are normally much higher than aldosterone. So, it can act like aldosterone. Now, a protective mechanism that we have is this enzyme that converts cortisol into cortisone, which is an inactive metabolite. Okay. So, when this happens, aldosterone is not going to be affected, and the mineralocorticoids will only respond to aldosterone. So, cortisol is not going to come and bind to it. Okay. Now, what happens when we have this enzyme that is going to become deficient or blocked? Basically, it's going to cause cortisol to bind to the mineralocorticoid receptors, and it's going to mimic mineralocorticoid excess. So these patients are going to present with sodium retention, water retention, hypertension, and potassium loss. We're going to talk about this in the next slide. So stay with me here. Now, a few causes of something that can cause a few causes of the deficient enzyme. We have firstly we have a genetic deficiency of this enzyme, and secondly we can have a few things that can directly inhibit this enzyme. So an example of that is carbenoxolone. Carbenoxolone is a drug that can inhibit this enzyme, and then we also have licorice, which is a type of food that when we take it, because it has this glycyrrhetinic acid, which is going to inhibit this enzyme. Okay, so make sure you know about licorice because this is the most high yield one over here. You can inhibit this enzyme and you can present with these effects. Now let's talk more about the effects that we just talked about. So when we have high aldosterone, what's going to happen? We're going to have sodium retention. Excess cortisol binding is one cause. No. Um, no, the cause of this disease is only when the enzyme is deficient. The excess cortisol, it always is, sorry. So we have excess cortisol in our bodies, right? Now this enzyme is going to take that excess cortisol and it's going to convert it into an inactive metabolite. Okay, but when we do not have this enzyme, then the excess cortisol is going to stay and it's going to come and bind to the mineralcorticoid receptor. So the cause of this disease happening is because we have a deficient enzyme. 11 beta HSD. Is that clear? Yeah, so licorice actually is a cause of this because it can inhibit this enzyme. So when we don't have this enzyme, and we're going to have the excess cortisol binding to the mineralocorticoid receptor. So this is why licorice is a main cause of this disease, because it can bind this enzyme. We have other causes over here. It can be a genetic cause, or it can be caused by a drug called carbenoxolone. I would say make sure to know licorice. Okay? Okay, so we said that when we have high aldosterone, we're going to have increased sodium reabsorption, increased potassium secretion, and alkalosis. Basically, we're going to be secreting more H+. If you remember here, these are the effects of aldosterone. Okay? H+ secretion. So the way these patients are going to manifest is because of the sodium retention, they're going to have a hypervolemia. So they're going to have hypertension and also edema. Okay, so because they're going to take in more sodium and more water, so their body volume is going to increase and cause hypertension and edema. Okay, now because we're losing too much potassium here, because aldosterone causes the increase of the potassium secretion, we're going to be in a state of hypokalemia. Now, just know that potassium is important for for muscles, for muscle function, and also the heart function, and also the bowel motility. Okay, so these patients will present with muscle weakness, arrhythmias, and constipation as well. Okay, and when we're talking about alkalosis, because we're losing more H plus is being secreted. This means so alkalosis is going to manifest as tetany and cramps. So these patients are going to have a lot of spasms. Okay, so this is how a patient with mineralocorticoid excess syndrome can present. These are the effects of hyperaldosteronism because you're taking in more sodium, you're secreting more potassium, and you're in a state of alkalosis because you are secreting more H+. Okay? Does anyone have any questions before we move on to my questions for the first two lectures? We still have another lecture after that. Is everything clear? Should we move on to the questions? Okay. So Bismillah, first question. The image below shows the tubular fluid over the plasma ratio for several freely filtered substances along the length of the proximal tubule. Which of the following best describes the proximal tubule reabsorption of the substance represented by line 3? D. Okay, D. Good job, guys. Yes, it is D. So as we said, but chloride is going to be reabsorbed later on in the proximal tubule. So it's going to take time to be reabsorbed. And eventually, when it does get reabsorbed, the water reabsorption happened more. Okay, so this is why it's going to have a ratio more than 1. And this is why it's going to be reabsorbed at a rate slower than water reabsorption. So you are absolutely correct. Next question. colonic crypt cells were studied in order to see whether aldosterone and ADH act in the GI system the same way as they do in the renal principal cells, where they act in which of the following ways? Anyone else would like to answer? Okay. Yes, exactly. Good job. So it is A, actually. So we said aldosterone is going to increase the sodium reabsorption and potassium secretion. And we also mentioned ADH that is going to cause the water reabsorption. So you are perfectly right. Good job. Now, our last question here. A patient has the following labs: potassium 2.2, sodium 145, and bicarbonate 60. Which of the following is the most likely cause? Exactly. Good job, guys. We just talked about this right now. This was the last part that we mentioned. We mentioned that when we have high aldosterone, again, we're going to have potassium secretion, sodium reabsorption, and H plus secretion. Okay? So I hope if you guys have any questions, let me know. So this is it for the end of the first two lectures. I think let's take a 10-minute break and then come back for the third lecture. What do you guys think? Or do you want to continue? Yeah, okay, let's take a 10-minute break. Bicarbonate over here. Okay, so basically bicarbonate is the base. طيب? And we said that aldosterone is going to increase the secretion of H plus, which is an acid. So when H plus gets secreted, so this means that we're in an alkalotic state. And when we're in an alkalotic state, we're going to have high levels of bicarbonate because bicarbonate is a base. Okay? Does that make sense? We're losing H plus. H plus is an acid. Bicarbonate is a base. Okay, perfect. So let's take a break for 10 minutes and then we'll be back. So exactly 4:50, we'll be back, inshallah. Oh, secretion. Okay, so for that, let me go back to the previous slide. 1 second. Okay. Yes. So remember how here we talked about okay, I think I know where you're confused. You're confused about this pump exactly. But when we're talking about potassium secretion, we're talking about this channel, okay? This does not matter to us unless we're talking about hypokalemia or hyperkalemia, okay? So yeah, so when we say we have more, like we have H plus that is being secreted, because look at we have two pumps over here. So more H plus is going to be taken out, and then a little bit of potassium is going to be taken in. But essentially, the major effect that is going to happen is from this channel over here. Okay, we're going to have more potassium secretion in the fluid. So I do get your point, but it has a minimal effect over here. The main channel that we want to look at is this one. Okay, I know it can be a bit confusing. But guys, I promise you, yani, with repetition, inshallah, it will all stick in your head. Yes, exactly. You got that right. Okay, let's come back after 10 minutes. If anyone has any more questions, please drop them in the chat. Okay, thank you. Okay, so Bismillah. Now we're going to start with our last lecture, which is urine concentration and dilution. Okay? This lecture is basically you're going to learn a concept from the beginning, and then every slide is just going to add on from the previous slide. Okay, so it's a shorter lecture compared to the other ones. Inshallah, it's going to be nice. Let's start. Bismillah. Okay. So before we start with the lecture, we need to understand something. So we already talked about how our bodies, they make certain toxic metabolites. And of those, for example, there can be drugs, there can be toxins, there can be creatinine, everything, all of that. And when you combine all of those together, they're going to make almost 1,200 millimoles, okay? And obviously, again, as we said, our body cannot keep those toxic metabolites. It needs to excrete them, okay? So we want to excrete all of those solutes, all of those metabolites. And if we did that normally, so if we did that with water, we would have to take 1 liter for every 300 milliosmoles, okay? So it means in total, we're going to need 4 liters of water to excrete all of those metabolites. Now, that is not really possible because it's just not compatible with life, and it's going to make us very dehydrated, and it's too excessive. Okay, so our body, another way for our body to compensate for that is that it's going to try to concentrate urine, and also at the same time going to try to reabsorb as much water as possible. So we're going to try to lose as little water as possible while concentrating the urine, so we can excrete all of those solutes in our urine. Okay. Now, this is just a quick review. So we know that this is our nephron, and we know that it is divided into 3 areas. So we have the cortex, we have the outer medulla. Repeat. This one. How does the kidney do that? This is what we're going to see in the lecture. Are you talking about this slide? Oh, the box. Okay. So this is just and it puts an idea in your head. We have a lot of metabolites that we need to get excreted into from our body. Okay. So in total, we have 1,200 milliosmoles. طيب. Now, what's going to happen here is that if we excrete all of them with water, we're going to have to excrete around 4 liters of water, which is a lot. So all you need to know from here is that if 4 liters of water is going to be a lot to excrete all of those metabolites. So the way our body compensates for this is that we're going to try to concentrate the urine while also reabsorbing as much water as possible. So we're not losing that much water because 4 liters of water, and it's going to lead us to become dehydrated. Okay? So we're going to see how urine gets concentrated. Is this fine? So basically what I want you to know is that we're going to try to concentrate the urine while also losing as little water as possible. This is the idea that I want you to get from this slide. So again, this is just a quick review. So we have our nephron here, and this is part of the cortex. This is part of the outer medulla, and here the inner medulla. So this is just based on the renal anatomy that you know, okay? Now our main guy over here is the inner medulla. We're going to be focusing a lot on the inner medulla in this lecture. طيب. So, okay, so before that, we are going to review a few more basics. So osmolality, as we have already covered it before, it's basically how concentrated a solution is. So it's how much solute a solution has. So if it has a lot of solute, it's going to be hyperosmolar. If it has a little solute, it's going to be hypoosmolar. طيب. Now, tonicity can be a bit tricky, but just focus with me here. It's basically how where water is going to move. Okay, so let me give you an example. Let's say you have a solution, okay, that has a lot of solutes. This is the extracellular volume, طيب. And then you have a cell. So outside of the cell, there's the extracellular volume that has a lot of solutes, and inside of the cell, it does not have a lot of solutes. So you can think as those solutes as magnets, okay? So those solutes, they're going to act as magnets, and they're going to try and pull the water from inside of the cell, okay? So this is what happens over here in a hypertonic solution. We're going to have a lot of solutes outside of the cell, so they're going to pull water from the inside of the cell to the outside. So the cell is going to shrink. Okay, now the opposite happens when we have a hypotonic solution, which is basically when we have a cell that has a lot of solutes and the outside of it does not have a lot of solutes. So basically those solutes, again, they're going to act as magnets and they're going to pull the water inside. So the cell is going to swell. Okay, so these are just some basic overview of the terminology because they're going to come up a bit later. And so yeah, just so you're not confused. Is this fine? Is it good so far? Okay. So now to make concentrated urine, we have two main steps. The first one is to build a hypertonic medullary interstitial, and the second one is to use a countercurrent multiplier. Now I know this makes absolutely no sense to you. Even the first time I read it, I was like, what the hell is happening? So we're gonna go into it step by step, do not worry. So first, this is a slide from your lecture. Again, do not be scared. I know it looks very scary with all of the arrows and all of the numbers, but it's very simple and it's very straightforward. So our goal in this step over here is to build a hyperosmolar interstitium, okay? Now, just to orient you, this is the interstitium. The white part is the interstitium, and these are the tubules. طيب. Now, here, this is the descending tubule, and here is the ascending tubule. Can anyone remind me what were some special, like, what are the features? How is the descending tubule, descending limb related to water? And how is the ascending limb related to water? We mentioned it in the tubular functions lecture. Exactly. Descending is permeable to water. What about the ascending limb? Yes, exactly. So ascending limb is impermeable to water and it is responsible for reabsorbing sodium chloride. So this is very important for you to know here, okay? So, okay, let's start. First, before we get into the individual steps, we're going to start with the starting point. So our starting point is this one. Now, let me ask you a question. We talked about the tubular fluid in the proximal tubule, and we described it in a certain way. Does anyone remember what is the fluid at the end of the proximal tubule, like in terms of tonicity or even osmolality? Like how is the fluid at the end of the proximal tubule? Because we had a lot of reabsorption in the proximal tubule, so to help equalize the tubular fluid and the interstitium, so we had okay, so we actually had an isotonic fluid. طيب. And we had an isotonic fluid, and as you can see over here, everything is equal because we have equal osmolarities all over, which is 300. So we're going. Basically, what you need to know is that the fluid from the proximal tubule was isotonic, and it had an osmolality of 300. So far we are only having the fluid from the proximal tubule come in, and the osmolality all over is the same. طيب. So we have equal osmolality all over. So we do not have any gradient yet, which is not what we want. We want to concentrate, we want to make a hyperosmolar interstitium, which is basically this, by the way. This is our interstitium, and our goal is to make it hyperosmolar, which means concentrated. Why is it isotonic? So we talked about in the proximal tubule how water reabsorption occurs with all the solutes. So what the water reabsorption is there in the proximal tubule to help balance out the solutes in the plasma and also in the tubular fluid. So this is why the fluid in the proximal tubule was isotonic or isoosmolar, basically. Basically, they're equal on both sides. Okay? Because we had a lot of water reabsorption over there. Okay, so this was our starting point again. So we said that the fluid from the proximal tubule is going to be isotonic, which means that we're going to have an osmolality of 300. So we have so far an osmolality of 300. We do not have any gradient. So this is why our next step is to go create a gradient. So we're going to go with step number 1. Okay, step number 1, I'm going to give you just the straight facts for every step so that it sticks in your mind. طيب. So the step number 1 of building a hyperosmolar interstitium is to build a gradient of 200 milliosmoles between the ascending limb and the interstitium. Okay, I'm going to repeat this. So we want to create an osmotic difference of 200 between the ascending limb and the interstitium. And how is this made? By the reabsorption of sodium chloride, because we said in the ascending limb we can only reabsorb sodium chloride. So we're going to reabsorb sodium chloride, and this is going to give 100 milliosmoles to the interstitium, making it 400. So now we're building a 200 milliosmol gradient difference between both of these. طيب. So now can anyone compare the osmolality of the interstitium compared to the osmolality of the ascending tubular fluid? Yes. Very good. So the interstitium is going to be hypertonic, yes, and it's also going to be hyperosmolar. So the osmolality of the interstitium is going to be higher compared to the one of the ascending limb. As you can see, we have more solutes over here. It's more concentrated in the interstitium, and it's also going to be hypertonic. And we said that when a solution is hypertonic, meaning that it's going to have a lot of solutes, so those solutes are going to act as magnets. So they're going to want to pull water. But the problem is in the ascending limb, it is impermeable to water. So how can that happen? It's going to happen through the descending loop. So I just jumped a few slides over here, but I just give you a preview. So again, step number 1 is to build a 200 milliosmol difference between the ascending limb and the interstitium, and this is done by the reabsorption of sodium chloride. Okay, this is it for the step number 1. Step number 2, as I just explained, is to reabsorb water through the descending loop. So the goal of the second step is to actually equalize the osmolality between the descending loop and the interstitium. Okay, so when we reabsorb water, we're going to have an equal osmolality of both sides. Okay, so as you can see, osmolality is equal from both sides. And also, previously, the interstitium was hypertonic, so it wants to pull in water. And it did that through the descending loop because the descending limb is permeable to water. طيب. So this is it for the step 2. So again, step 1, we're building a gradient of 200 milliosmol between the ascending limb and the interstitium. Step 2, we're making an equilibrium between the interstitium and the descending limb. Okay, so we're having equal numbers of osmolality between the interstitium and the descending limb, and we do that through the reabsorption of water. Okay, now step 3, what's going to happen here is that we know that fluid is constantly coming in from the if the water is going to listen, because no, we want to concentrate this one, the descending limb. The interstitium was already at, sorry, 1 second. Yeah, so this is step 1, right? So we made the interstitium at 400 over here, okay? And then we're going to have water reabsorption to concentrate the descending loop. Okay, so those were the first 2 steps. The descending loop you didn't get. Okay, so okay. Listen, guys, just know the very direct steps of all this process, because later on it is going to make sense. The more you repeat it later on, it's going to make sense. Even for me in the beginning, I was very confused, like, why is this happening? But all of these rules or steps, they happen for a certain reason, so which we will see later, inshallah. So again, we said the first step is to build a 200 milliosmol difference between the ascending loop and the interstitium. طيب. Then the second step was to make an equilibrium between the descending loop and the interstitium. Okay, and this happens through the reabsorption of water in the descending limb. Okay, that is it. That's all you need to know from this slide. You don't need to know into the little details actually of like why does like how and everything. Just know it's like straight facts. Okay, like water is going to be reabsorbed, and we're going to have an equilibrium from both sides. Okay, so then what happens is that we know that fluid is constantly coming in from the glomerulus, so it's constantly being filtrated through. Okay, and we said earlier that the fluid in the proximal tubule is isotonic, which had an osmolality of 300. Okay, so now we have new fluid coming in into the loop. We have 300 milliosmol, 1 unit of 300 milliosmol coming in. So what's going to happen here is that everything here is going to shift 1 unit. So the 400 that was here on top is going to shift down. This is going to shift down. Everything is going to shift 1 unit down. And over here we had 400. This 400 is also going to move to the other side. So why is that a problem? Because as we said, we wanted to build a 200 milliosmol difference between the ascending loop and the interstitium. But now that this 400 is here, we broke the gradient. Like 400 and 400, they're equal, خلاص, and there's no gradient. So this is why this breaks the gradient and it's going to trigger the next cycle to occur. Okay, so after this, basically everything that we just explained is going to happen again and again and again. And the reason why it keeps on happening is because, again, remember the main goal of this whole process is to make a hyperosmolar interstitium, which is here. So we're going to concentrate the interstitium as much as possible. And I know for now it's not going to make sense to you guys why, but again, we will see that later, okay? So again, we're going to go over the cycle again because we broke the gradient over here. So this is going to trigger the cycle to happen again. So the first step is to build a 200 milliosmol gradient difference between the ascending loop and the interstitium. The second step is to equalize the osmolality between the descending limb and the interstitium, which is done here. And then finally, we have a new fluid that is going to come in, a new unit of fluid that is going to come in and is going to shift the fluid to the other side, which is going to break the gradient. So we want a new gradient to be made. So this is again going to trigger the next cycle to be made. So over time, we're going to have a few rounds of this cycle occurring until finally we get to this point, okay? Now this point over here is when the interstitium reaches an osmolality of 1200. And at the end of this process, you're going to notice three things. So the first one is that at the end of the descending loop, the osmolality is going to equal the one at the interstitium, okay? The second thing you will see is that when you go up the ascending loop, you're going to see that the tubular fluid is very dilute. It's getting even more dilute. And that's because we have sodium chloride reabsorption. We said that the ascending loop is impermeable to water. So water is going to be left behind inside the tubule, and we're going to have sodium chloride reabsorption, and this is going to dilute the fluid. This is going to be important later on when we mention it. And one last thing that we're going to see here is that the interstitium is going to become very hyperosmolar, and the maximum osmolarity you're going to see is at the tip of the interstitium, which is present in the medulla. Do we have a picture of the? No, sorry. Okay, so we said that this part of the tubule is present in the medulla of the kidney, correct? So the maximum osmolarity that you're going to see is at the innermost part of the medulla. Okay. So basically what we want to produce from here is a dilute fluid. And we have a hyperosmolar interstitium. It's going to make sense later on. Because I know right now we said that we said the main goal of this whole lecture is to make concentrated urine, which clearly this is not happening because we have the tubular fluid and it's very dilute and this is not concentrated at all. And we're going to see later on why and what happens. But I just want you to stay with me here. So right now we're making a hyperosmolar interstitium, okay? And one more thing to note over here is that urea is also going to help make the interstitium hyperosmolar. I'm not going to go into it right now because we will mention the urea later on in the lecture, but just keep that in mind. So urea will also help make a hyperosmolar interstitium. Okay. Now, okay, vasa recta, this is something that I don't think is very important, but it was mentioned in the notes section of your lecture. So vasa recta basically is a loop of capillaries that goes around the loop of Henle. And its job is basically to take away any solutes or water, any excess solutes that are present in the interstitium. So we know how we had reabsorption occurring in the interstitium. So it's basically going to take any excess, it's going to remove it. So we have this the cycle can keep on going. Okay, that's it. That's all that you need to know from the vasa recta. It's just going to maintain the environment that is needed to concentrate the urine. It's going to preserve the hypertonic gradient, basically. So it removes any excess solutes here, okay? You don't need to know much about the vasa recta, that is it. Okay, so again, earlier we talked about how we want to make a concentrated urine. Now let's see at how it actually happens. Our main character over here is ADH. ADH, as we said earlier, on the tubular functions lecture, we said that it acts at the late distal part of the tubule and the collecting duct. What is it going to do? It's going to cause water reabsorption. Okay, so this water reabsorption, we said that it was dependent on ADH. طيب. So, okay, as we said earlier, let's go over this loop. So we said the tubular fluid at first in the proximal tubule is going to be 300 milliosmoles. Then it's going to go down the descending limb. It's going to get concentrated. And then as it goes up the ascending limb, it's going to get more dilute. And then as it reaches the distal tubule, it's going, because of it, thanks to ADH, we're going to have water reabsorption. Okay, so when we're removing water, what's going to happen? We're going to concentrate our urine. So our urine is going to be even more concentrated. So as you can see, the more you go down, the more concentrated it gets because we have more and more water being reabsorbed. So we have 300 milliosmoles and 500 until we reach our desired target, which is around 1100 milliosmoles. Okay, I'm going to repeat this. So we said that ADH comes at the late distal part of the tubule and the collecting duct, and it's going to cause water reabsorption. Okay, now when it reabsorbs water, because our fluid that is coming from the ascending limb is already very dilute, so it's going to reabsorb water to make our urine concentrated. So this is how our urine gets concentrated because of ADH. Okay. So again, we saw this slide. We saw where ADH acts. It's going to act in the late distal tubule and collecting duct. And now, what happens if we do not have ADH? Okay, so we said that ADH is going to help us to make a concentrated urine, right? But now, if we do not have ADH, we're not going to have any water reabsorption. So the water that was present in the fluid is going to stay there. Okay, so as you can see over here, the tubular fluid is already very dilute, and Because, okay, how does water reabsorption concentrate urine? Because you have a tubular fluid that is filled with water and solutes. When you're taking away the water, the solutes are going to stay behind. So this is going to concentrate. So the solutes, when the solutes are high or hyperosmolar, this is going to concentrate the urine. Yeah, exactly. So what happens when we don't have ADH? When we don't have ADH, so there's not going to be any water reabsorption that's going to happen. So the water is going to stay within the fluids, which means that we're going to have a dilute urine. And as you can see over here, our urine is very dilute, and it gets even more dilute because we have some sodium chloride that gets reabsorbed in the collecting ducts. Okay, so it gets even more dilute than that, and it can go as low as 65 milliosmoles. So without ADH, we will have a dilute urine. With ADH, we're going to have a concentrated urine because of water reabsorption. Now, first checkpoint. Do you guys have any questions? I know the first part was a bit confusing, but again, yani, with repetition, guys, I promise it's going to make sense, inshallah. You just need to know the very direct steps of everything. Okay. So we talked about ADH already, and we said that it is responsible for water reabsorption in the late distal tubule and collecting duct. Now, something that we did not mention already is that it can also increase the urea reabsorption in the inner medullary collecting ducts. And this is going to be very important. So again, ADH can increase the water reabsorption, and it can also increase the urea reabsorption in the inner medullary collecting duct. And I brought this picture again to show you. So we have here the inner medulla. As you can see, this is the inner medullary collecting duct because all of this is the collecting duct. So the inner medullary collecting duct, we're going to have urea reabsorption, and this is controlled by ADH. ADH is going to increase this urea reabsorption. Now, let's look at how urea is transported across a nephron. So in the proximal tubule, we're going to have urea reabsorption reabsorption in the proximal tubule, and then in the descending limb, we're going to have secretion, and then in the inner medullary collecting duct, we're going to have reabsorption again. That is mediated by ADH. Okay, now let's look at each section of the nephron and how this happens. So in the proximal tubule, urea is going to be reabsorbed paracellularly through solvent drag. Now this is not very high yield, it's not that important, so I just included it for completion's sake. But again, you don't really need to know this. What we're focused more on is the next part, which is the secretion and the reabsorption in the inner medullary collecting ducts. Now, the secretion is going to happen in the descending loop of Henle, as we said earlier, okay? And it's going to go through these channels. These channels are called UT2 transporters, okay? So urea will come from the blood and it's going to get secreted through these UT2 transporters into the descending limb of Henle, okay? Then in the inner medullary collecting duct, we're going to have urea reabsorption through the UT1 and UT4 transporters. I wouldn't say you need to know these transporter numbers because it's not that high yield, honestly. But I just included them for completion's sake. But as long as you know urea transporter UT, you'll be good, inshallah. And as I mentioned earlier, this part is going to be controlled by ADH. Okay, so ADH is going to increase this urea reabsorption that will occur in the inner medullary collecting ducts. Now, urea. Okay, yeah. Now let's talk about the permeability of urea. This is important. So in the cortex, urea is not permeable at all. Okay, it cannot move in the cortex at all. When you go down to the outer medulla, it starts to get a bit more, slightly more permeable. Okay, but it's still very slightly. But now when you go to the inner medulla, as we said, it is the major part where urea acts. In the loop of Henle, as you can see, it is a bit more permeable. But in the inner medullary collecting duct, this part, it is where we have the maximum permeability of urea. Okay, make sure to focus on this part here because it is important. So when you're asked what is the maximum area, what is the area that is the most permeable to urea, it is going to be the inner medullary collecting duct. Okay. Now urea, as we said earlier, is going to be important to make the hyperosmotic medullary interstitium. Okay, because it gets reabsorbed, so it's going to make it more hyperosmotic. So okay, this is everything that I said. Oh no. So the reason why it's not permeable over here in the cortex and the outer medulla is so that we do not lose urea too early. Okay, as you see here, we have secretion of urea. So we're going to add the urea into our tubular fluid so that we have a lot that can be reabsorbed. And then the function of this urea reabsorption in the inner medullary collecting duct is to keep the medullary interstitium hyperosmolar. Okay. Just know this for urea. It's going to keep the medullary interstitium hyperosmolar by the reabsorption in the inner medullary collecting duct. Okay, guys, we're almost done. Don't worry. We have like, I think 4 slides left. Okay, so now this is something that you already know actually. And okay, so let's go over this graph. So here we're looking at the tubular length over the osmolality. Right? We said that in the proximal tubule, the osmolality is azoosmolar. Okay, so we have around 300 milliosmoles. Okay, then when we go to the descending loop, we're going to have concentration, and then when we go to the descending loop, we're going to have dilution. Okay, now up to this point over here, everything is the same. These two are, I know they have a slight difference, but you can disregard that. Basically, both of these lines are going to be the same. Now, what's going to happen? ADH is going to choose the difference after the late distal tubule. So starting from the late distal tubule, we're going to see a difference based on if ADH is present or ADH is absent. Why is it permeable in the loop of Henle? Are you talking about the urea? Because it has these transporters. I'm not sure about the exact reason why, but it is permeable. That's what you should know. So it is permeable in the descending loop of Henle. Because we want to increase the urea concentration in the tubular fluid so that more can be reabsorbed over here in the inner medullary collecting ducts. Yeah, this is secreted over here. Okay. So let's continue. So, okay. Okay, I think you're confusing permeability with reabsorption. When we say permeability, we're talking about how open and solute can pass through. It does not only mean about it's not only talking about reabsorption. So when we say this area is highly permeable, it means that it can either be reabsorbed or secreted, depending on the situation. Okay, but the permeability does not only associate with reabsorption. Okay. So now again, this graph. So we said that prior to the late distal tubule, everything will be the same. After the late distal tubule, ADH is going to decide whether our urine gets concentrated or diluted. So if you can look over here, when we have ADH, our urine concentration is going to get very high. So we're going to have a concentrated urine. But when we do not have ADH, our urine is going to stay dilute. Why is that? Because without ADH, we're not going to reabsorb water, as we mentioned earlier before. So water is going to stay within the tubular fluid and it's going to stay dilute. Okay, so we kind of already mentioned this graph in the previous slides. So yeah, this is everything that I just explained. So now, okay, what situation can decide whether ADH is going to come in the collecting duct or is going to not be present? Okay, so we have two situations. The first one is when we're taking a lot of water. So when we're taking excess water, as we said earlier, our bodies, they cannot handle excessive things. So when we have a lot of water, our body is going to try to get rid of that excessive water. Okay, so this is why ADH is not going to be released. We're going to have low ADH because we do not want to reabsorb the water. We want to keep it out. We want to excrete it, okay? And when we are excreting that excessive water, it's going to cause our urine to become dilute. And this excessive water is called a state of diuresis. And now an easy way to remember this is diuresis, dilute. So, die. So easy way to remember that. So basically, again, when you're in a state of diuresis, basically you're taking a lot of water, ADH is going to be low, and your urine is going to be diluted because you're not reabsorbing any water. طيب. Now, on the other hand, if you're in a state of water restriction, so for example, you're stranded in a desert, so you're not taking in any water, so you're going to be in a state of anti-diuresis. Okay. Now, in a state of anti-diuresis, ADH is going to be high, and as we mentioned earlier, ADH, both the actions of ADH is that it's going to increase the water permeability, or basically the water reabsorption in the late distal tubule and collecting duct, and it's also going to increase the urea reabsorption in the inner medullary collecting duct. Okay, so what's going to happen here is that because we have ADH, we're going to have reabsorption of water, so we're going to have a concentrated urine. Okay, and also thanks to urea, because it's keeping the medullary interstitium hyperosmotic, it's going to keep the gradient going, and it's going to again help in keeping our urine concentrated. Okay. So I made a summary table for you guys. So when we're in a state of water restriction or anti-diuresis, the ADH level is going to be high. So we're going to have high water reabsorption. We're going to have high urea recycling, and our urine is going to be concentrated. Okay. But when we're in, yeah, sure. Okay. So again, the effect of urea directly, it can be a bit confusing, but basically what you need to know is that it's going to cause it's going to increase the hyperosmolarity of the interstitium. Let me go back. Yeah, so over here, this is our interstitium, correct? And urea is basically just going to increase it because it's being reabsorbed. So it's going to increase the osmolarity of this one. I know it can be a bit confusing, but just know this mainly because it's going to help to make our urine concentrated. Okay. So again, when ADH is high, we're going to have the effects of ADH, which are water reabsorption and urea reabsorption. And both of these are going to help to make our urine more concentrated. So, okay, when we're in a state of excess water, our ADH levels are going to be low. Our water permeability, we're not going to have any water reabsorption. Urea recycling is going to be low, and our final urine output is going to be dilute. So when we want to make a concentrated urine, we want to have urea and water permeability. So we can have water reabsorption and urea. Now, this is the last graph that we're going to see today, inshallah. Okay, so here we're just comparing the tubular length over the water percentage of the over the water percentage. Okay, so we talked in the tubular functions lecture about water reabsorption, and we said that it is reabsorbed in two main areas. I'm not talking about the late distal tubule. Prior to that, we talked that it is reabsorbed in two main areas. Can anyone remind me what they are? So they're actually the proximal tubule and the descending. Oh, okay, sorry. So we're talking about the percentage of water. And previously in the tubular functions lecture, we talked about the reabsorption of water. We talked about two main areas where water was being reabsorbed. Do you remember what they were? Like areas of the nephron that were reabsorbing water. Exactly, good job. So we have the proximal tubule and we have the descending limb, okay? Now the proximal tubule reabsorbed about 65% of the total water. So that gave us with the remaining 35%, okay? And of that 35%, we had 15% more that was being reabsorbed in the descending loop, okay? So basically what I want you to know here is that we're left with 20%. Now this 20% is the one that is going to be dependent on ADH. Okay, so if ADH is present, we said that we're going to have water reabsorption. So the water concentration or the water percentage is going to go low. Now, if ADH is not present, so this 20% is going to be excreted in the urine. So our water concentration is going to remain the same. This 20% is going to remain the same. So what I want you to know from this slide is that basically we have 20% of the total water concentration that is going to be controlled by the late distal tubule and collecting duct. Okay? Because 65% was reabsorbed in the proximal tubule, so that leaves us with 35%. It depends. Okay, let me just repeat. So again, 65% gets reabsorbed in the proximal tubule. This leaves us with 35% of water, and then of that 35%, we have 15% that is reabsorbed in the descending limb. So this is a total of 80% that was reabsorbed. So we're left with 20% of water in the tubules. طيب? Now, this 20% of water is going to enter the late distal tubule, and depending on if ADH is present or not, we're going to have water reabsorption. Okay, so if ADH is present, this means that we're going to reabsorb the water, so the water percentage is going to go low. Okay, and our urine is going to be concentrated. Okay, but now if ADH is not present, that means that we're not going to reabsorb any water, so the percentage of water is going to stay the same. Is this clear? Okay. So this is everything that I explained, but in words. Now, just a few normal values that the doctor wants you to know. I'm not going to go over this because I think this is covered in your GFR lecture, which is more relevant there. But basically, a normal person the urine volume of a normal person is around 1.5 liters a day. Okay. Now, the minimum that it can go, or the lowest that it can go, is 0.3, and the highest that it can go is 16. I'm talking about the urine volume, and this is dependent on ADH. So again, if we have high ADH, meaning we have water reabsorption, so we're going to have a very concentrated urine, and the urine volume is going to be very low. طيب. Now, if we have low ADH, which means that we're not going to have any water reabsorption, so the water is going to stay within the tubular fluid, so it's going to cause a very high volume of urine to be excreted. Okay? So the lowest you can go is 0.3, highest is 16. And the normal average normal for a normal person to excrete in one day is 1.5 liters. Now this is our last slide of our lecture. Okay, so basically, obviously he's not going to ask you to know the different values for each animal. But he just wants you to understand the concept. So basically, we know that a beaver is an aquatic animal, okay? So it lives in water, basically. And so we can assume that it's taking in a lot of water. And we said that when we're in a state of excessive water intake, our body wants to excrete the excess water. So you're going to see that the urine osmolality concentration is going to be very low because we're going to basically because we're not going to reabsorb any water. So there's going to be a lot of water in the urine of the beaver because the osmolality is going to be high. No, sorry. The osmolality is going to be low. Sorry, I mixed it up. So we're going to have a low osmolality, but yeah, you're going to have a low osmolality because the beaver has a lot of water. So you want to get rid of all that water. Okay. I know it can be a bit confusing with all the hormones. Even I'm getting mixed up right now. So again, a beaver is an aquatic animal, okay? So they take a lot of water. So they're in a state of excessive water, okay? Now our body, whenever we have excessive something, we want to get rid of it. طيب? So we're going to try to excrete all of that water. So what's going to happen? We're not going to have ADH release because we said that ADH is going to cause the reabsorption of water. So we don't want that. We want the water to be released, to be secreted or excreted. And we said that when we have a lot of water, basically the osmolality is going to be low because the solutes are going to be diluted because we have a lot of water in the urine. So this is why when you look at the osmolality of a beaver, you're going to see that it's pretty low. Okay, but now compare this with a desert spring mouse, which is an animal that lives in the desert. So obviously it's going to be dehydrated. So its body is going to want to keep as much water as possible. It's going to retain as much water as it can. So here in this case, we're going to have ADH secretion. So we're going to have reabsorption of water. And when you look at the osmolality of the urine of this animal, you're going to see that it's very high. Okay, it's very high because we have a lot of water reabsorption, and we have solutes that are going to get secreted because we're taking in as much water as we can. So this is basically just a concept that we explained earlier, but it's just applied to animals to understand it better. Does that make sense? Okay, perfect. So, okay, let's move on to questions. So I have 3 questions for you guys, and then we'll be done. So the first question is, which of the following segments of the nephron is least permeable to water in the presence of ADH? Okay. Anyone else would like to answer? Okay, good job. Yes, so it is C. So here they're just trying to trick you and think of ADH. Oh, is it going to be the late distal tubule or whatever? But no, no matter what happens, the ascending loop of Henle is always impermeable to water. Okay. Next question. Urea is a key component of the urinary concentrating process. In which part of the nephron is the permeability of the luminal membrane to urea the greatest? Anyone else? Okay, so yes, it is E. We talked about this earlier. We said in the inner medulla, the permeability of urea is actually highest over here. Okay, now last question. In normal kidneys, which of the following is true of the osmolarity of renal tubular fluid that flows through the early distal tubule in the region of the macula densa? Yes, perfect. So we said that the fluid that would come out of the ascending limb is going to be very dilute, okay? And when it enters the distal tubule, it's going to be very dilute. So this is why it's going to be hypotonic compared to the plasma, okay? So Does anyone have any questions? So again, this is my number, this is my email. You guys can contact me at any time. Last one, okay. So for this question, basically, when we talked about, let me go back to the figure. Okay, so for example, over here, we said that when the fluid was going up the ascending limb, it was going to get very dilute. It was getting very, very dilute, right? Because we only have sodium chloride reabsorption and the water is being left behind. So the fluid that is going to enter this part, which is the early distal tubule, is going to be very dilute, okay? Now, when we have this dilute fluid, we can describe it as hypotonic or hypoosmolar. So this is basically what the question is asking you. It's basically asking you what is the like terminology for this fluid, basically. And the answer is hypoosmolar or hypotonic. Because it does not have a lot of solutes compared to the plasma. Does that make sense? Okay, thank you. Does anyone else have any questions? You guys can contact me at any time for any questions you have, because I know this can be a bit confusing. We have a lot of hormones and a lot of mechanisms, but feel free to contact me at any time. And please scan the QR code. I would love to receive your feedback. And yeah, بالتوفيق. All the best, guys. I wish you all the best.